Please, I just paid $500 on a cruise for next year. And that's like, you know, take it off my test. I got to find foods where I gotta see 45 times. His family and her. I don't know if they're that's different. Roy, sometimes we're going on the. Let you leave. Oh, no, put that. Yeah, no, like spacious. That kind of ask us. I got this. I'm starting.
Big possibilities.
The attendance QR code up there. I did post an announcement. I think Thursday maybe about the rest of your semester after last week. It will be a combination of Professor Rafi Vallis and Dr. Persons who will be taking over for me because I only signed up for the first 6 weeks with Bill. Because I would like to have a little bit of my summer off. I will be your faculty for 331, but that's all online. So we'll just be hanging out online together for that. So there was one switch in the topical outline that makes it where you are missing a day of class, which I'm sure that y'all were devastated by. So pay attention to that. I did post the announcement. It switches content because I felt that it was more important for you guys to get information on medication administration and pain management as opposed to bowel elimination. That can be discussed via a voice over thread with no problem, but pain management and medication administration is pretty important. So just swap those two dates for content, and then I don't remember the dates off the top of my head, so make sure you check that. This will take up there's no class. So there'll be like a little online quiz or something that will be made up for that content time. Any questions about that? Alrighty. That made me real sad. Okay. Feel good for the day. Do your little bit of good wherever you are. It's those little bits of good put together that overwhelm the world. And don't we need that? Do your little bit of good every once. So, question for you guys. When you hear us throw the term around critical thinking, what does that mean to you? We throw that around all the time, right? Put together the critical thinking aspect of this. What does that mean when you hear that?
Say engaging with any input that you have in front of you, so not just taking things and running with it or being programming somebody else says, it's thinking for yourself.
Okay, all right, I like it. What do you have? You had your hand up too?
No, I just have my hand.
Oh, yours.
I was thinking with my hands.
Thinking with your hands. That's a new one, not just talking with your hands, but also thinking with your hands. All right, what else? What else do we have? I know know there's more ideas.
The like patient-centered care with this.
Okay. All right, so we're putting it all into that patient-centered care idea. I like it. What else?
I think about that. I think about coming into my place of work and thinking about which patients need the most attention up front. And thinking about their situation, what they're going through, their level of acuteness. And using my judgment based on what I learned in school.
Okay, all right. So initially, that's kind of hard to put into words, right? So we're throwing at you critical thinking and expecting you to start utilizing it right away, right? To start putting all those pieces of the puzzle together when maybe your puzzle is kind of this smeared gray of when you have a really icky pencil eraser and it like makes it really ugly. You know what I'm talking about, where you're like, oh man, I got to throw a whole pencil away, right? And you're like, well, but it doesn't exactly make sense yet. Maybe, yes, I've memorized what the right vital signs are for a patient. And I've memorized what it means for a patient to be alert and oriented times 4. And I know what that's supposed to look like. But how do I start putting those pieces together, right? So I like Russell's idea of what does it mean when I first walk into work and I have to decide what these pieces look like and start like prioritizing everything. When I worked in the ER, my favorite shift was 11 to 11. 11 a.m. to 11 p.m. was the best. Man, got to sleep in a little bit. You needed to have an appointment. Got that done in the morning. I could go get my oil changed before work. And you hit the ground running, right? Very often I would come into work. We were 4-to-1 for nursing ratio. And all my rooms were already filled. If I was lucky, some things had already been done for my patients, but very often they were just, hey, your room's already filled. Go for it. And I'm clocking in as all my patients are filled. As opposed to when I got there at 7, maybe a nurse was handing over a patient or 2. And I was getting a report on that. But I'd be lucky to be looking up at the board and seeing patient name, the general complaint, and being like, oh, okay, well, I got 2 abdominal pains, a toothache, and a chest pain. All right, let's go. Right? And so having to put all of those pieces together and decide, well, is that toothache really a toothache, or is it jaw pain in a little old lady who might actually have chest pain, and I need to go figure that out further, right? So those pieces that I have to put together are what we start to think about when it comes to critical thinking. And that's what we're digging into today. And it takes up, chapters 15 through 21, I think. So we start with clinical reasoning. And that idea that we are looking at clinical decision-making and critical thinking. And we are constantly making decisions when it comes to clinical decisions. We're taking each piece of the puzzle that we're given, and we're making these assessments that need to be quick and on the nose, like what's happening with that patient. And they change rapidly. Every single time I take a peek in the room and say, hey, how you doing? Can I get you anything? I may notice that my patient's starting to deteriorate, that their mental status has changed some, that their color's a little bit different. That maybe before, when they were sitting up in the bed, they were looking very comfortable and doing fine, but now they're kind of scrunched over and appear to be in pain. Because we assess with every single one of our senses, right? I mean, man, we assess with our sense of smell. Look, listen, feel, smell, C. diff down the hall, right? So we make these rapid decisions all the time. And the more you are doing things, the more those clinical decisions will come at a more accurate and rapid pace. To where you're not having to kind of slog through all of that information. Right now, going through that information could be like you're trying to, I'm gonna date myself, go through a Rolodex of information. For those of you guys who are younger, do you even know what a Rolodex is? Looking at me like,
Yeah. So you used to
okay.
Is it like a little box of people's address and shit?
Yeah, so sometimes they were round, sometimes they were a box, but it's all this card information. You used to fill it out, have names, addresses, phone numbers, and you go through alphabetized to see what information you find. Or what is it, the card? We have them at the library, the card, Dewey Decimal System. Card catalog, thank you. Where you're trying to find information, right? But right now you're getting all that information as you're learning, and it's so dense and so heavy that it can be really hard to kind of find the pieces that you want. Now, we utilize critical thinking in our everyday personal lives. You make those decisions. Can I get from Colorado Springs to Pueblo with the amount of gas that I have right now, or should I stop and get gas? And I know that sounds really silly to think about it like that, but we make those decisions every day. You know, do I have time to stop? Right. Do I spend the extra 5 cents a gallon? Because weirdly, Pueblo's gas is more expensive than Colorado Springs.
It's cheaper if you're going to
Oh, see, it's cheaper in Pueblo than it is in Fountain. Like, so we make those decisions every day. Do I grocery shop today versus Friday when I have a little extra money? Do I pay this bill versus that bill? Do I spend time studying? Or do I go for a run because it's better for my mental health? Right? So we make critical thinking decisions every day. Now you're going to translate that information into nursing practice. But in nursing practice, it has to be a learned tool because you're taking pieces of information and applying it to patient care. And unfortunately, patients do not come with instruction booklets. They don't come with here is, my name's Heather, and here's all of my information. If you do X, Y, and Z, then here's the perfect way to treat me. Wouldn't that be nice? It would be so perfect to be like, oh, man, I can do everything for this patient, right? So when we looked at critical thinking, there is the one definition that is the ability to reason, analyze, research, infer, and amend. Meaning, I can look at all this information, analyze it, research if necessary, infer that information, and then amend it if I need to. So if at any point patient status changes, I can go back and say, oh, wait a minute. I did have a stable blood pressure, but now I do not. I got to change it up. Or I had a patient who was alert and oriented, and now I do not. Right? We use that based on new, well-supported information to make informed decisions. And it was already brought up once that we use patient-centered care as part of this. part of that well-supported information is patient-centered care, which we have not always done. That has not been a big aspect of nursing. We've talked about it, but we're more and more focused on the person being at the center of care. According to the text, it's important to remember that this is a continuous process. This is not like a one and done. All right, I did my assessment, moving on to the next thing. We do have to be very open-minded and constantly in search of new information. And then we need to look at each patient individually and understand that as an individual, those patients are always going to be challenging that aspect of critical thinking, because no person is going to be alike that next person that you take care of. You could have two 42-year-old men that appear on paper to be exactly the same. You're taking care of them for chest pain. They are rule out acute myocardial infarction, and on paper they could be exactly the same and have two drastically different courses of care, because no two patients are ever going to be the same. And recognizing the individuality of those patients is really, really. Now, when we look at clinical reasoning, it's important to recognize the big picture. Because if we start to hone in on those very small things, those small details, you hear the phrase, you can't see the forest for the trees. So it's that idea you're looking at each individual tree and not recognizing that there's this big forest. So we want to make sure that we're recognizing that you can kind of take a step back and look at the entire picture of what's happening with that patient and see that there are small details of what's going on. So let's take, for example, our patient who may have a change in mental status. There's lots of different reasons for a patient to have a change in mental status. We can have it related to, are they having enough oxygen get to their brain? Do they have enough sugar in their system? Do they have some type of infection? Those are just some simple ones that we can think of right off the top of our heads, right? So what is happening with that patient to then start to rule out what's going on? We want to be open-minded when it comes to taking care of our patient. So already my favorite question is why? Why does my patient look like this? Why are they acting like this? Why is their blood pressure like this? Why is their mental status changed? I absolutely despise it when somebody documents patient non-compliant. Why? Why is your patient non-compliant? Victim shaming. Think about what's going on with that patient. If your patient, you're talking to them about their medications and they say, no, I don't take that medication. Okay, tell me more. Well, my doctor took me off that medication. Okay, great. Let me document that. Oh, I can't afford that medication. All right, let me document that. I'm gonna get social services involved or our case manager involved. Let's see if we can get you some vouchers for that. There's a medication my brother was on when he was waiting for a liver transplant. $700 pill, taken twice a day. Took it for 10 months. Kept him from going into hepatic encephalopathy, which kept him from being absolutely, pardon the language, batshit crazy. There's really no other way to describe her having subclone. $700 a pill. Anybody here can afford that? What?
I wouldn't be here if I didn't.
Yeah, no kidding. Probably be picking a different profession, right? So, you know, when we talk about patients being non-compliant, why? I joke that I'm a nosy. I wanna know. Sorry, my language is bad this morning, I apologize. No, I seriously, I am like, so tell me more. I wanna know all the things. Give me information. Me and your boyfriend did that. Are you serious? This is terrible. I mean, that gives you. We are bonding with our patients. We are creating that sense of confidence in the care that I can provide for them. You are becoming. What other job do you have that somebody within the 5 minutes of meeting, you're asking them, so what was your last period? How many sexual partners have you had in the last year? Any chance you could be pregnant? I mean, seriously. You have to find a way to connect with your patients that give you like, hey, come on now, we're besties now. Like we have to find a way, right? The next thing that I want you guys to think about when it comes to critical thinking is that you are constantly learning. Consider yourself from here on out a professional learner. That idea of constantly searching for new information, whether that's critically thinking about your patient, critically thinking about a new diagnosis, evidence-based practice, all of those things help you to become a better nurse. That idea of why, that critical aspect of what's happening helps you to be a better nurse. There's not one single textbook out there that can give us all the answers. Because patients' bodies are crazy. You're gonna have that patient who's like, I've never once been by the book, so who knows? My labs are always wacky, my diagnoses are always crazy, and that's true. And you're gonna have some wild diagnoses out there. We jokingly call them looking for zebras when you really mean horses. Because they're just so out there. They're wild. You're just like, wow. You have some very interesting diagnoses. And they're fascinating. Those are not the ones that we test on when it comes to the NCLEX. They're fascinating, very interesting, but they're not going to be a textbook case. Occasionally you'll get really lucky. You'll be like, how? You actually are what the textbooks are written about. This is fun. But you also have all of the rest of the things that happen with being a human being. Life is for these people. They're coming in with problems that go on outside of being a patient. You're meeting them because they're in a hospital setting, in a medical need place. So you can't just isolate them as their diagnosis. You have to think about them as the people that they are. If you're taking care of the sole breadwinner for a household, what other stressors are happening that are making it to where it's harder for them to concentrate on getting better? If they're the ones who are missing a week or two of work, are they now concerned about putting gas in their car and food on the table, paying for the medications, getting their kids to and from school? What other aspects? Think about that. Ask them. What priorities are keeping them from actually being able to focus on getting healthy? It's those aspects of critical thinking that make our job a lot more complicated. And then comorbidities. So let's think about that patient who has a sudden change in mental status. They're getting enough oxygen. They have a new infection. Their blood sugar be low. Well, if we have comorbidities going on, how could those be impacting a current problem that they're in the hospital for? Maybe my patient was admitted for, let's admit them for a cardiac condition. New onset arrhythmia. New onset arrhythmia. Their heart's doing some funky things. Right? And now they have an altered mental status. I have to remember what other things, those comorbidities, their admitting diagnosis, how could that impact what is happening with that patient right now? Well, because of that new onset arrhythmia, I'm worried that my patient could have had a stroke. That can happen with those new onset arrhythmias. So all of these things could happen in addition to something as simple as blood sugar's low, oxygen could be low, maybe a new infection. So we're constantly, our brains are constantly going. So if any of you guys know nurses, you wonder why they come home so tired, starting to make sense. So we constantly make objective and appropriate clinical decisions. So thinking about that patient with that new onset change in mental status, how bad is it? Is it they're just a little bit confused? Sit them up, have them do a couple of big coughs, check their vital signs. They realize their oxygen's at 88%. Throw them on some oxygen, it starts to clear. All right, we're doing good. They're doing much better. And that arrhythmia just causing some funkiness with their oxygen saturation. Versus, check their vitals and their blood pressures in the toilet. It's like 60 over Jesus. And I decide I need to call a rapid response because I don't like that and I need to nurse with friends. Right? That's where our nursing judgment comes in. How else do I have to work within the confines of my abilities? It's how I advocate for my patients. I make informed decisions based on the information that I have regarding that patient. That lifelong learner, continuously building on the knowledge that I have. You're working on a cardiovascular floor, becoming more familiar with the patients that you have, types of care that you get. And I'll tell you, I worked for many years in the ER, loved it. Very much a jack of all trades, master of none. Very good at a lot of different things. And then I was like, oh, I'm going to go try something different. When I worked in outpatient surgery and orthopedics and spine and felt like an absolute imbecile. It's like, I don't know jack squat about putting on this fancy dancy sling with the poofy pillow and putting somebody into a back brace. I don't know how to do any of this and felt very, very dumb. So I had to continuously build my knowledge base on how to do all of that stuff. Now I'm super judgy when I see people out like you're wearing your stuff wrong. And my husband has to be like, stop it. Don't go help them. That's very, very uncomfy. I mean, it's better. I don't anymore. Okay. clinical reasoning skills. So some important things that we could do is interpretation. We look at the information that we have and we decide what to do with it, right? My blood pressure, 120/80. Do I like it or not? Yes, that's beautiful. O2 sat, 85. Ooh, not so much. Right? I'm gonna have to analyze that and go, how am I going to navigate this information? So thinking about if your patient tells you they have chest pain, what are you thinking? What is your first thought? Based on information from this class as well as 302. If your patient tells you they have chest pain, what's your first thought?
It's traumatic or is this a medical thing?
Okay, traumatic versus medical.
How's your breathing?
How's your breathing? What else do you want to know?
Scale.
Scale of, what scale are you going to put it on?
Pain scale.
Pain scale, 1 to 10, all right.
What does that pain feel like?
What exactly do you feel like? Okay,
Patients.
taking any medications? So see, we got lots of questions we want to ask them, right? We don't just go, okay, you're having chest pain, cool. Right? You know, it's not that you're not gonna be like, oh, sucks to be you, right? No, it's like, all right, so tell me more. When did this start? What were you doing? Does anything make it better or worse? Have you had this pain before? Do you have any history of any cardiac history, any family cardiac history? I want to know, is it a male or a female? Where exactly is your chest pain? Chest pain like here? Is it chest pain like here? Does it radiate anywhere? There's so many questions to ask, right? I also want to know, what do they look like? Right? Are they pale, sweating, or diaphoretic? They kind of like, I'm having some chest pain. Yeah, it's real bad. It's real bad. Or are they like, yeah, I'm having some chest pain. No, it's like a 10. Versus my having chest pain. It's like a 4. You a farmer? Rancher? Who brought you in? You drive yourself? Did you fall off a tractor? Fall off a bike? Did you just land here in Colorado from Florida? You're having difficulty breathing with that. What are their vital signs? And you can make this instead of 20 questions, 50 questions, right? So how do we get our clinical reasoning skills better? Why? Why? And then the next question, what am I missing? Kind of like sometimes, I don't know, so it's, you've ever seen something redacted, like a court document or something like that, and there's like blacked out pieces of information. Sometimes I feel like patients give you redacted data. And you're like, oh man, feel like missing important pieces of information. So patient tells you, no, I don't have any medical problems. Let's take our chest pain guide. I don't have any medical problems. Everything's fine. And then you say, you're like, I feel like I'm missing something here. And you say, well, are you taking any medications? And he's like, well, yes, I'm on metoprolol. You said you don't have any medical problems. What do you take your metoprolol for? Well, high blood pressure. So you have high blood pressure? No, not anymore. I take metoprolol for it. Okay, what other medication do you take? Lisinopril. Oh, what do you take that for? Oh, for high blood pressure. That you don't have anymore because you take some. What else do you take? Simvastatin. Oh, so you have high cholesterol? No. I take simvastatin for that. What else do you take? Metformin. What do you take that for? My type 2 diabetes that you don't have anymore. Also, right? What was your last A1C? 9.6. Okay, then your metformin's not really working for you, but. And so you start to get this picture of, I'm not missing a lot. He's redacted a lot of information because maybe he doesn't understand and has not had great education about what his health really is, and we're gonna have to do some good education and make him a better med list because this is really frustrating. And then what are my options here? What do I have to do next? Well, if there's anything that I need to fix immediately, let's say his oxygen came back at 88%, man, let's start him on some oxygen. Or is this normal for him? I took a blood sugar, 205. Sir, have you been checking your blood sugars? Well, sometimes. Was 205 normal for you? Oh, yeah, I bet it is with the A1C at 9.6. I bet it is. And then what do I need to do regarding the data I collected? What do I need to do with that? Am I just gonna, yeah, absolutely document, or am I just gonna like collect like little eggs and then sit on them like a chicken? You're like, huh, yeah, it's just some information I'm gonna keep. Nobody needs to know. Absolutely not, because some of that information really impacts how that provider's gonna care for them. And physicians don't have time to like go combing through all the data that I've collected on that patient. They need the cliff notes. If I'm in the ER with them, I'm gonna need to go, hey, yeah, this 40-something-year-old male came in, chest pain, sudden onset of sudden chest pain, history of high blood pressure, high cholesterol, type 2 diabetes. Takes the total by Lisinopril. And I'm just like highlighting, right? Because they need the down and dirty of what's happening. Now, the patient's probably going to give them the redacted version or some nature as well, but we still need to be able to give those cliff notes. Consider that learning is always going to be this lifelong process. It builds knowledge. There's also lots of different ways that once you're into your field that you want to be in, that you can expand that knowledge, becoming like a clinical nurse leader, as well as other like specialties that you can do. But this causes intellectual growth, involves new learning, new knowledge, and kind of solves that itch that you have to keep on, to keep with that. I want to know more. You wouldn't be pursuing a second career or a second degree if you didn't have that itch that needed to be scratched, right? And nursing science does continue to progress. We have changes that have been made based on evidence-based practice, and which is awesome. So we need to understand the necessity of flexibility, accepting that new information, and being willing to be part of that change. How can we be part of evidence-based practice, pushing that change forward and ensuring that our patients are receiving the best care? So other ways that we work to develop clinical reasoning skills, and you'll see this within both working on it in our lab, but also in your clinicals, is reflective journaling. And this is really just looking at what you've either done that day or other, like for in your clinical setting, recalling the situations and what your personal perceptions or observations were, and then concept mapping. So this is that visual representation of the patient problems, interventions, and the interrelationships between them. And that helps you to visualize that patient in the middle, and then how does that go with each of the issues that are going on with that patient. So let's take and let's practice this. So you take your friend's blood pressure. Their blood pressure is 139/89. So what would you do? Yes.
Get a manual because the automatic blood pressure code is wrong.
Well, you're practicing, so it's 138/89 because you're practicing for 302.
Okay.
Are they as paid?
So it would have been a manual.
I would ask people to die.
Retake it.
Okay.
Retake it, even that.
Ooh.
That's what I was.
Oh, I like it. Beautiful. All right. So you're like, wait a minute, did I even get that right in the first place? Okay. All right, I like it. Okay, what do they usually get? What other health problems do they have? It's getting pretty personal with your friend. No, I like it. Ella, did you have something?
I just said retake that.
Retake it, okay. Would you retake it on the same arm or a different arm? Switch the arm, okay. So what if you get 136/82 on the other arm? Then what? So would we say it's accurate or not?
It's accurate, but I'd still reassess in like 5 minutes.
Okay, all right,
Are they in pain, any kind of pain, is it pain related?
okay, all right. Why does that matter?
Because if it's pain related, then it elevates your blood pressure because your body's in pain and so it's working.
Okay, excellent, excellent. Yes,
Most of the people ask if they're like stressed out right now, or if they just had a bunch of caffeine, I don't know about.
all right. If they're a fellow classmate, they're probably ingesting the caffeine and could possibly be stressed. Depending on if you have an exam a week, like you might be doing right now, 2 exams a week. You're like, only 1 exam a week? That'd be easy, right?
Oh, that would be funny.
Because I think you guys are, what, at 2 exams a week right now? Oh, just 3. 3 exams a week. That's it, a week deal. What other question that I haven't heard yet? Did anybody say, do they take any medications? Anybody say that? So there's 2 different aspects. So do they take any medications that, like antihypertensive, but there's also medications that increase blood pressure, which we'd also be concerned with, right? So if you're on any sort of stimulants, that could increase their blood pressure. So good job. So that's just thinking, and I love the very detailed of 139/89 and how it should be. All right, so when we look at the nursing process, this is that interrelated critical thinking, clinical reasoning, putting it all together. And this is a systematic problem-solving process. And it guides all of our nursing actions. The purpose is to simply provide goal-directed, patient-centered care. And the nursing process is going to be part of every single thing that you do, every single day. The idea is ingrained in every single nurse and needs to be part of what you use to help answer and solve questions. So it's really important to have this as part of your like basis for what we do. Right. So the nursing process defines what we do, and it differentiates our role from any of what the provider does. So physician, NP, PA, whatever they're doing, it's very different from what we're doing. It starts with assessment. We go to prioritize, plan, implement that plan, and then evaluate. And we're gonna go through each one. When we start to go through this, part of this is looking at how to systematically collect and analyze the data. The creation of that plan is meant to meet our patients' needs. And we apply the nursing process to both well and sick patients, doesn't matter. And eventually, like right now, it feels very clunky because you're learning the process. But eventually it'll just be, this is what we do. The NCLEX is designed according to the nursing process, which is why it's important to understand what this is, as some of the questions are very much related to which step of the nursing process the question is asking. When we write concept maps, that plan of care is included in there, and you're putting it into a paper process. Once you put that plan of care into writing, we know it's going to change. Just because it is down on paper doesn't mean that that is now set in stone. It will evolve because patients are not static. They don't just remain in this, in this glass box once you have determined this is what you're going to have them be. And I know this is a little bit late since y'all have been working on your concept maps for 3 weeks and you're presenting them tomorrow, but concept maps actually take the information that you know and understand about a patient and apply them within the practice situation. It's far more elaborate than a hospital care plan, and they're really used to help you to understand the process of planning care. So it's more than just having you put down the information and do busy work. It really is the idea of how your brain forms these neural pathways to understand how patients, like everything starts here and flows out from that. And it makes it to where when you're functioning as a nurse, are you going to make care plans and concept maps? Absolutely not. But it will just automatically, like, that's how your brain's gonna function. I promise. It's very weird. All right, so it used to be ADPI, this prioritize actually used to be diagnosed. So if I say ADPI, just disregard, that's how I learned, but it's ABPI. So we start with assessment. So this is simply gathering information. We are going to get all the data that we possibly need, which you guys did in lab. You gathered up everything you could get on your patient. Some people had more information on their patients than others. But this is everything that you could know about your patient. It can be from your head to toe physical assessment. It could be subjective, objective. It could be previous lab work where you're having trends in the labs. It could be a CT scan. It could be, no, my husband, he is so bad about taking his medications. He says he takes them, but I know I see his medications on the counter and they are the same every single day. I don't think he's taking them, right? So we have all these data points. So that is how we get our assessment data. So remember, our subjective data comes from patient or family. This is going to be our best source of information, especially when we collaborate that information from other providers. So both patient and spouse say that the patient has had ongoing chest pain for 6 hours. Great, that's been collaborated. That information is same. Objective data, medical record, the physical assessment data that we get when we do our assessment of the patient, lab data, vital signs, diagnostic tests, things that can be physically done, right? The information that we get. The key to individualizing that care plan or that concept map is really part of the assessment. You may have a patient who has the same medical diagnosis as their roommate or the person next door, but they may have very different interventions and very different key points that you need to work on with that patient. So take for example, that patient with chest pain who's not been taking their medications, maybe they need a lot more education and interventions regarding that than the person next door who needs interventions regarding fall safety, because they still have a whole bunch of area rugs and an iguana at home that gets out all the time. Right, so nursing health history, this is all of the places we could get data, right? Biographical information, what does our patient expect out of this? Some of that you're gonna get just by talking with that patient. Why they came in. I'm here because I have chest pain. Great, tell me more. Not great that they have chest pain, but health history, family health history, any spiritual health that you can help with them, psychosocial history, review of systems, think of that as your head to toe, or depending on what's going on with your patient, a very focused assessment, and then documentation of your findings. Then we look at cues and infers. So if I have a patient who is laying there looking very comfy in bed, I may document that patient resting comfortably in bed denies need for pain medication when I ask them. Versus the patient who has not moved, has like a grimacing face, has been like, they're kind of like scrunched up. There's a cue that I'm like picking up on, and then I can infer what their pain is, especially if they're not able to communicate, and what that pain does for that patient. So the cue may be that they're grimacing, and that they are not moving, they're not moving in bed like they should, or they've not gotten up at all. And then when I ask them their pain, in this case it says 7 out of 10, then I infer that their pain is severe and that pain is limiting their ability to move and reposition. So there's a difference between a cue and then what that information infers. Does that make sense? So if my patient is tripoding and they're like leaning forward and only doing like 2 or 3 breaths or 2 or 3 words every few breaths, those are some cues. And what does that infer for me? Yes, they're having difficulty breathing and I'm probably going to have some sort of potential respiratory issue on hand, right? So the difference between those, because you're gonna have, those are some big things when it comes to NCLEX style questions. Looking for the cues. And then what can that infer in my answer? What are those cues within the question or the data that it gives me? What can it infer within those answers? Little NCLEX style question hints right there. All right, so previously it was at 5, we had diagnosis. It is not a diagnosis within nursing. Is not recognized by any other medical personnel except nurses. The patient care was related to the medical diagnosis. It got very confusing when we called it a diagnosis because it's not a medical diagnosis, it's a nursing diagnosis. And it generally reflected some type of alteration of structure or function. And so it was under NANDA, which was the nursing diagnoses. So examples were activity intolerance, and it would have as related to, as evidenced by this whole thing, and it was very frustrating. So they decided that we do still have them in many nurse practice acts. However, and you do have it in your unbound, in your nursing central. You can look up nursing diagnoses. However, if you have to use nursing diagnoses, it needs to only be from the approved ANDA list. And you can find it in the Tabor's dictionary. However, we use priority problems now. So that is the new current expectation. Because that is more in line with what nursing is doing and more in line with the expectations of the NCLEX. So we do prioritization of care, and that is based on the assessment of your patient. So when we are, even if our assessment is not yet complete, an example would be for checking the O2 sat on a patient recently admitted with pneumonia. The result is 92%, then I can make the assumption that their respiratory status is okay. Because even if I haven't had a chance to do a full respiratory assessment, that priority at that moment is okay. I will go back and do the rest of my respiratory assessment, but in that moment, we're doing okay. Now, what if my assessment is inaccurate? That is definitely a concern. So if I check a patient's vaginal bleeding after a C-section, but if they are laying supine in bed, and I only just like take a peek, they haven't gotten Epidural, then I may make an inaccurate assessment of what's going on with that patient. Or take, for example, that patient with pneumonia, 92%, but they have not ambulated at all. Or they have, their oxygen was plugged in, and then now it is not. So there's a lot of information that you need to make sure is accurate and not just assumed quickly. So it cannot just be a quickly done. Okay. So how do we prioritize? We have to determine which patient need to address first. So with our pneumonia patient, their medical diagnosis is related to respiratory. They may have underlying diagnoses of hypertension or we'll just give them hypertension for now. So our highest priority is going to be that immediate threat to patient survival or safety. Now, they may also be a fall risk because they have an IV and they've got oxygen and they're weak. They've fallen in the last 6 months. So they may also be a fall risk, but is that going to be my highest priority in care for that patient? No, absolutely not. So then we look at intermediate problems, which is non-emergent, non-life threatening, and then low priority, which are actual or potential problems. And that's how we go through and prioritize, which you guys should have been working on as you go through your concept maps. Okay, and then remember those potential risks, a problem that may develop, a problem that's likely to develop if the patient is vulnerable. So think about our older adults and their potential for fall risks. If there's no current signs or symptoms to support a potential diagnosis, then you can ask yourself what could potentially develop. And then don't forget to look at that big picture. So what could happen if a bedbound patient has dry skin and a weak pulse, and that potential for skin breakdown? If somebody is not eating well, they have an infection, those types of things that our patients are at risk for. So let's take a 10-minute break. Then we'll be back and practice some of these risks.
No, that's.
They're just going to like us that and like kids. They're self-paced, but it'll like diminish us like. Yeah, it's the same. You can like.
This person is weeks.
3-4 ish is fine. When you get out of sure like that, about like 7. Use the links.
So like.
I know I
Oh yeah.
The day before.
We used to know like.
Yeah.
There's nothing in the life. Well, there's something like that. But next year, I'm pretty sure it's this stuff.
It's 110, but like. Yeah. So you could be inside.
one thing that
Not like that's like.
Like how we registered back in like. We're still in. Yeah. And yeah.
Yeah, so
Yeah, like the.
is that
Yeah.
But you have until like. Not until. Your medication.
Like it just goes on like.
Is like a question that we frequently like to ask is reassessing pain after you've given a pain medication. And it depends on the route. So if you gave an IV pain medication, when would you need to reassess their pain?
15 to 30, right?
It's what?
15 to 30 minutes.
15 to 30 for IV pain medication. What about oral?
1 hour?
Yeah, 30 minutes to an hour for oral pain medication. And it depends because of how quickly things are absorbed. So IV pain medication is much quicker. So 15 minutes, to 30 minutes, and then oral is 30 minutes to an hour.
I don't want to do that, but like, I'm gonna do that. So,
Is that your way of saying this is a dumb question? You cannot rephrase it like that.
okay, well. It's just like,
If you have that question, somebody else probably has the question.
right, but it's like as an instructor seeker, it's just like, okay, but, anyways, I was thinking. Would you say that this is one of the more challenging checkoffs, just because it's more about what we know, knowledge, not necessarily performing this step by step?
No, not necessarily, because you have resources in order to, you have resources.
Yeah, this is right over almost or whatnot, or like I typed this.
I thought we could use that as a reference point also.
Okay, for this, it's this, and this. You could reference it and be like, oh, yeah. Levothyroxine, make sure you take it on an empty stomach, it's for your thyroid, I want to make sure that my patient's thyroid levels are within, check. I mean, it's.
So we would keep going back to those essentials. We can like kind of side effects and stuff with those.
Yeah, it's not a,
No.
it's not a, you just can't sit there and like have this held up to your face the whole time going, I levothyroxine, okay, Keflex, it's an antibiotic. I want to make sure that my patient isn't having really bad diarrhea the whole time. And I want to make sure I take it with food. Oh, yeah, that means you can't do that. So are we gonna be able to open nursing central, or you can open nursing central if you're more comfortable with nursing central and you've heard it nursing central, the meds on nursing central, then go for it.
We can just be like, oh, what's that?
Yes,
Oh.
you can even turn to your friend and go, I just completely blanked. Might give that. Wait, hold on. Let me take a deep breath. I'm gonna turn around for a second. You guys need to remember, our intention is to not fail you. We do not start at the start of the day and go, we people. Okay, hold on, I got some packing parts in the back that I haven't filled out yet. Seriously, no, our intention is to make sure that you are safe to go and get meds when you start clinicals in 2 weeks. So the biggest thing is the 6 rights in medication administration. Those ones I don't want to see written down on your paper. I want you guys to know those backwards, frontwards, upside down, and in 5 languages. I'm just kidding, you don't need to know them in 5 languages. No, seriously, like that's stuff I want you to know. You're gonna go and get meds at the long-term care center and not know those medications. You'll have never seen them before. Can you pull them up on Nursing Central and go, oh my gosh, I have never seen this medication. I need to look it up before I give this medication to this patient because I want to make sure that it's safe to administer this medication. And I want to know how to do it.
And I don't want to take up all your process, because it's like, so what is the format of it going to be like? The same as the other checkoffs where we go to the station and it's like, okay, I think we have an order for this medication. Go get that.
It'll be like, all right.
I don't know what it is.
You're gonna be giving you're gonna hand me your sheet. You're gonna give the second 30 meds. And you're gonna give and the patient needs, patients in pain. So they'd like some pain medication, and you're gonna give how about you give the 2100 meds, And, oh, the patient needs vasopressin stat. And whoever wants to go first, go for it. So that's how we start generally. And then we over there. So we have like our little station set up. And whoever goes first starts to get their meds. So, let you gather your meds. That is your bedroom. And then you like move to the side. There's your patient room. Because it's just on a bedside table.
So we don't have to offer any that fee.
Are we doing the scan and iPad stuff?
Oh, yeah, that's first step. So you just go move to the side. And you're now in your patient room. So you'll say, I am gathering my meds and I'm checking them against the MAR. Because you'll have your MAR with you, check them against the MAR. I have my 730 meds, I have my pantoprazole, I have my insulin. Oh, and did the patient say what their pain scale was? I don't know, you probably should ask them. All right, Mr. Kent, what is your pain right now on a scale of 1 to 10? My pain is a 5. So then you look on your pain scale back here. Well, yes, because it's an order.
Like on that page specifically that you were holding, like we're like, oh, 1 sec.
Well, you have your MAR. You have to have a MAR in order to be able to pull meds. Because that's what it's. Oh my gosh, no. That'd be so horrible.
That's what I thought it was. So I was
No,
like,
no, that'd be so horrible. Yeah, so you would have to be able to look on here to see what your order is, because if we had you memorize this, then you are not doing safe medication administration by using your MAR to pull your meds.
I'm following.
Yeah, so then you go, okay, he's a 6, so my order is for acetaminophen and oxycodone, 1 milligram every 6 hours for moderate pain, scale 4 to 6. I'm gonna pull one Percocet, and then I'm gonna go to my patient room. Hi, could you please tell me your name and birth? Hi, my name is Mr. Ken, and my birthday is 2/3/65. What allergies do you have, sir? I have allergies to lactose and sulfa. I cannot drink milk. What? Thank you. Right? And then I have some medications for you today. Well, what do you do before you give insulin? Oh, I need to check his blood sugar. Verbalize it. And maybe we tell you that his blood sugar is 600, or maybe we tell you that his blood sugar is 60. Then we talk about what would happen. His blood sugar is 60, what would we do?
Hold it.
If his blood sugar is 60? If his blood sugar is 60, what would we do? Give me orange juice. Give him orange juice. If his blood sugar is 600, am I okay giving him his insulin? Okay. Yeah, so does that help? Put some minds at ease. You still look like I am smoking.
No, but I don't know, I thought that's nice to know, so like,
Yeah, you cannot pull meds without having a MAR of some nature, because part of your understanding of the meds is
okay,
right patient, right route, right dose, right time, right medication, right? And you don't know those rights without comparing them to something.
No.
Right? 0.
So do we have to inject
did you know this?
or like you just drop the medicine?
Do you have what?
Inject?
Yes, you're gonna inject into a pad. If you have an injectable medication, you're injecting into a pad. So you do need to know, like, you injecting at 90 degrees, 45. So you will inject into a pad.
I was just gonna ask you, is it usually like the MARS on the computer in the brain of the computer where the like
Yeah, so you have a Pyxis you would like go in with the patient's name and date of birth, and you would have medications to choose from. And that would be like your MAR on there, which we obviously don't have.
For the gauges, is there gonna be an expectation to kind of know like exactly what gauge to use for IM or?
Yes, like you're not going to be putting an 18 into for like a reasonable expectation. You would not be using an 18 to inject insulin into the belly kind of thing versus like but you're gonna have options there to use to pull up. So we will be paying attention to what you're picking. And there might be some guidance, like if you were to. Do you guys have blunt fill needles in your bags? So pay attention to the fact we will actually switch from drying up with a blunt fill needle and then switching to a needle to inject. If you cannot inject the blunt fill needle, please, the longest I do not inject the blunt fill needle. Well, no, if you're trying to do it on a real person, but you can on the injectable pads.
I guess I was just curious about, if you like, my bad notes, so if it's like, you I have like 90 degrees. For 45 degrees or a longer needle.
So if you have a skinny patient, and you don't have like good fat to grab gloves, you don't want to go like all the way into and end up being swollen. So that's why you do a 45 needle with our 45-degree needle with the longer thing.
Okay, but otherwise, you can do like that.
Yes.
So just to be clear, we're not using the insulin needling.
No, you will use the insulin needle for insulin. But there's the vasopressin and there's working IM as well. I believe. Yes.
We're using our own needles.
No. We'll have needles and insulin syringes and all of that in there. All right. We're good now?
So we don't have to bring our bag.
You what?
Bring your bag. We'll open your juice. We need.
You're learning IVs tomorrow. Yes. We're learning. Learning and not doing. I mean, you are doing, but yeah, not testing.
Oh.
We do not quote each other. Okay, now we're gonna practice. We're practicing devising a priority problem. Look at this patient. What priority problems do you want for this patient? Huh? Do they have an airway? I love it. I love it. What other thoughts?
What kind of trauma?
Cardiac problems? Is that what you said?
What is their mental?
What did you, that's it. Airway. Airway. Mental status, nice. Anaphylaxis, all right, I like it. Pain, yeah. Conscious, what's their level of consciousness? Yeah. So lots of good questions there. So airway obstruction. Because we don't exactly know what their condition is, right? Airway compromise of some nature is a concern. Impaired breathing, likely some condition. Like, ooh, what is going on? So major problem with this patient is we are worried about what our ABCs, right? Just at a glance, we don't know anything else about them, but our first thing is ABCs, right? All right. This one we have some more information. 54-year-old patient, recent knee replacement, discharged home a few days ago. Comes to the ED with fever, chills, increased pain of 7 out of 10, increased redness and warmth, purulent drainage at the incision site, and a white blood cell count of 19,500. Normal is 4,000 to 11,000. What's our concern here? Priority problems. Infection, sepsis. What else do we want to throw on there? Walrus, I like it. Pain, yeah. Pain, number one, they are post-op. Number two, they have told us they are having pain. I mean, that is a concern, right? Impaired mobility? What happens with impaired mobility? We got all sorts, we had a mess of problems with impaired mobility, right? Think about skin breakdown. Generalized weakness. Muscle wasting, depends on how long they're down, right? Increased risk for falls. All sorts of problems, right? All right, we got another one. 73-year-old with a diagnosis of kidney failure has 1+ pain edema, bilateral lower extremities, fluid restriction of 1,000 mLs, 24 hours. States he's so thirsty and wants you to give him a drink. What do? What is priority nursing action related to fluid restrictions? So we've kind of narrowed this down. First of all, 1,000 mLs. Y'all have Stanley Cups bigger than 1,000 mLs. You'll have emotional support water bottles. Okay. All right, absolutely. Yep. So so part of this is he's so thirsty and wants you to give him a drink. So you're gonna give him a drink, that's number one.
You have to see how much fluids he drank.
All right, excellent. We're gonna check and see how much he's already had. Oh, we got all sorts of. Go ahead.
But you could give them ice chips to wet his mouth and they'll melt slower, so they'll take it less.
Okay. And ice chips, do they count against his 1,000 mLs? Yes, they count differently, so you want to make sure you document accordingly.
Priority one. Why can't have a lot of water?
All right, excellent. I like it.
I'd also like to see the quality boots.
Okay, yeah, output is huge when we're looking at fluid restrictions, right? So when, I mean, he's out, that's a pretty strict fluid restriction when it comes to kidney failure. So how bad is it? Like, is he so close that he's ending up needing, that we're looking at dialysis, because 1,000 mLs is, and that's pretty tough.
Did you get like a, or like number something, just like active?
So you can, yep, you can do the swabs as well. The glycerin swabs that can help moisten his mouth. Remember that lemon drops will actually dry out the mouth, so, but peppermint and gum is okay. But education is a huge aspect of this. And wanting to make sure that he does not have anything in his room where he can sneak fluids. Like, don't leave the cup in his room. Don't leave a pitcher of water in his room, which that sounds like you don't trust the patient. It's not so much that, it's that if you're thirsty, you're gonna reach for what's there. Or you're gonna take it into the bathroom and fill up your cup because you're thirsty. And if you don't understand or don't care to follow the rules, don't want to follow the rules, don't feel vested in following the rules, whatever the reason is, you're inclined to get what you can. There also needs to be a very large sign on the outside of the door that says that he is on fluid restrictions and how much. And then somewhere in the room clearly documented how much fluids he has had. And everybody would then be marking up, so that he's well aware of how much he is able to have and how much he has left. The better the communication, the better it is for the patient and help him understand. Fluid restrictions is actually one of the harder aspects. It's easier with like sodium restrictions, potassium restrictions, because those have some alternatives, kind of fill in like salt restrictions. There's really good like spices and stuff that you can add. But when it comes to fluid restrictions, it can be really really challenging. Okay. So planning. So we talked about priorities, what we're looking at for priorities. And then now we need to establish our goals. What outcomes do we hope to achieve with our patients? And then we decide on those priority interventions, the things that we feel are most important. We prioritize those urgent actions that need to be done first. What is our desire to change in that patient's condition? And what is that priority turnaround? Like what needs to happen in order for that patient to look better, feel better, do better, whatever that needs to be. So how can we make that better? So thinking about that first patient with that very swollen face, one of our first interventions would need to be vital signs. What does that patient look like? How are they doing? Based on that face, I need to know what do their vitals look like? Are they actually breathing? I'm asking them questions and doing things. So that I know, do I need to intervene with some sort of airway? Do I have an airway in that patient or not? And getting a set of vitals while I assess that is going to give me a status of how quickly I need to intervene on that airway. All right, so Nursing Central. Pull up your Nursing Central. You do it online or on your phone, whichever. In the search bar, search for asthma. Your asthma, there should be the option of asthma in Tabors. Then you'll look at the definition and signs and symptoms. That's going to help you to prioritize. What does your patient look like? Based on those signs and symptoms. Then when you go back to search, you can look at asthma and diseases and disorders. And that can help you plan your patient care. The different ways that it is set up in Nursing Center.
Sorry, diseases and disorders.
Yes.
It's not here. Yes.
All the DX.
Yes.
Yeah, they have different symbols.
Oh, no.
Okay.
But
Okay, got it.
Right, so clinical reasoning on your concept map. This is where we start to look at creating our outcomes. And our outcomes need to be SMART goals. So we start with they need to be specific, meaning that this patient is going to do this thing. So let's take our first face swollen patient and make her a SMART goal. So let's use airway as our concern, right? Our priority concern for this patient is her airway. So what would we start with for her SMART goal? You want to put out there? What is that? Unobstructed airway, okay. So unobstructed airway by tomorrow. Like that. And obviously, I think it's really a long way away, given that that's. How about airway will remain unobstructed during her stay? So measurable with numbers. What kind of numbers can we associate with airways? Full box stays above 95. Breathing rate, okay. So breathing rate 12 to 20 and full stocks above 95. Can we make that achievable? Yeah, I can make that achievable either by intubating her or her doing it on her own, right? I don't really care how that happens. Her airway is going to be clear. I'm either putting a tube down it or I'm giving her medication or I'm doing something because I am not. And I would even put a time bound on that by the end of my shift because airway is scary. I don't want to mess around with her airway, right? So our outcomes need to be patient-centered. Want to make sure that we are understanding what that patient is able to do, what their highest level of wellness or independence is. So how do I find that out? How do I find out the patient's highest level of wellness or independence? You have to ask them, absolutely. I don't know what's going on with my patient unless I actually ask them. So if I say, my patient, and I joked last week, will I be able to play the piano after the surgery? Not if you didn't play the piano beforehand, right? Because if I don't know about my patient, I don't know, climbing the inclines beforehand, I cannot expect them to climb the incline afterwards. So for short-term outcomes, I want my patient's airway to be clear while I am caring for them. As evidenced by O2 sat above 95, respirators between 12 and 20. Those short-term goals are what we do, especially as students. And then long-term outcomes are days, weeks, months, things that are often looked at more like case manager nurse, because they're the ones who are dealing with what are those outcomes that we can see that are far more impactful for those patients that are looking at like discharge and stuff. So we want to write those desired outcomes in terms of patient's behavior. So look at patient will. Patient will have a clear airway. Patient will ambulate to the bathroom with minimal assist before discharge home. Does that mean post-op need? Patient will eat. Patient will choose low sodium, low potassium meals with minimal intervention by discharge. So if we look at the medical diagnoses, in this case dehydration, and then the desired outcome is the patient will have moist mucous membranes in 24 hours, indicating that the patient is becoming rehydrated, knowing that that medical diagnosis of dehydration has been addressed. Patient will have brisk skin turgor, again, looking at that dehydration as being addressed within 24 hours. And patient intake and output will be balanced in 48 hours. Recognizing that I's and O's take a little bit longer to balance than seeing moist mucous membranes and brisk skin turgor return. So do we think that these ones are okay? Patient's urine output will increase within 48 hours. Is that a good one? What do we need to add?
Much.
Okay, I like it. So if I went from, I don't know, being 100 mLs to 105 mLs, does that actually, I mean, it increased, but is that a successful outcome? No, I mean, that's, yeah. Patient's urine will be a better color within 24 hours. What's a better color? I really like red. That's a beautiful color. But for urine, right? So if I did patient's urine will be a straw color within 24 hours. But it has been, I don't know, pea color. Better. Like that. I mean, straw is way better than tea, right? I mean, tea color urine is not great. Encourage patient to maintain adequate fluid intake in a 24-hour period. Yes, no? Yeah, what's adequate? Because for our dude with 1,000 ml fluid intake, that's adequate for him. Because that's his fluid restriction, right? So what would we need to put in there? Yeah, patient will maintain fluid intake of at least 1,500 mLs, or will maintain a fluid intake of 1,000 ml per fluid restriction in 24 hours. Which, side note, when a patient is on a fluid restriction, as strict as 1,000 mLs in 24 hours, it is important for them to drink that 1,000 mLs because those kidneys, you guys are going to hear this all through 420. Kidneys are windable baby kidneys. Okay, kidneys, and we're actually seeing the nephrologist on Friday with my brother. Kidneys are windable babies, and they are hypersensitive. They don't like it when they don't get fluids. They don't like it when they get too much fluids. They don't like it when they don't get perfused. And they have to be like right after perfection. So if they're at 1,000 ml fluid restriction, they need that 1,000 mLs, no less, no more, for the windable babies. So, all right, for our appendix medication, pain is a priority. They have told you their pain is a 9 out of 10. Our cues are grimacing and holding their right lower quadrant. So I can infer that they are in pain, yes? Our desired outcome, patient will state pain is a 3 out of 10 during this shift. Or you can even put during my 7A to 7P shift. During patient will state he can manage pain within 24 hours. Even better, would be patient's stated pain, managed pain level is 3 out of 10 states you can manage pain within 24 hours. Because then you're very specific of what the patient says they are able to handle. And you're adding to that patient thinks they can manage pain. So be 3 out of 10 or less. And that makes it more patient-centered. All right, so implementation, we're adding that action into what we're doing. We want to again prioritize that care. We want to understand why we're doing it. What is the rationale for it? Evidence-based practice is what comes into play here. What is our expectation of that? If I'm giving pain medication for my appendectomy, my post-appendectomy guy, I want that pain medication to work. Any potential hazard from that is that pain medication could make him sleepy. It could reduce his respiratory drive. If they're narcotic naive, it could be really bad, and I could have them need some Narcan. I need to know what hazards can come from that. We want to ensure that we are doing assess, do, and teach. Those are important aspects of implementation. Doing the things. And teaching is oftentimes a big part of the doing. When I've done it, I got to reassess. Did the thing I did work? Do I need to do it again? Do something different? Any complications? Any changes? If I'm doing a head to toe assessment and I have to stop at my hugely swollen face on that first gal, because I have to implement something, a massive intervention because she's got a bad airway, I gotta start over at the top because I had to do something urgent with her airway. It may take me a while to get past my ABCs because I have to keep reassessing the ABCs to keep her stable. Maybe I don't even get to do musculoskeletal because I'm staying here to keep all of this stable. When we're looking at the rest of planning care, we're looking at what do those treatments and actions look like based on that clinical judgment that we're working on, that we're building, that knowledge that we know about the patient. How is that impacting those patient outcomes? What am I doing with that patient that is impacting the outcomes, those desired outcomes? There's some things that are absolutely grounded in scientific reason, scientific rationale. I put on compression hose or SCDs because that rationale is to ensure that my patient is having interventions to reduce the risk of developing a deep vein thrombosis. But I also am going to get that patient up and have them walk as much as possible if they're able to reduce that risk for developing a VT. But that depends on my patient's ability to do that. So I have to understand their psychomotor, their psychosocial, my ability to communicate with that patient. And we use every single piece of that as we move throughout the day. And understanding the resources that we have available. Now, keep in mind, when you are in NCLEX world and you're functioning with an exam mindset, you have every resource you could possibly want or need. So it says utilizing healthcare resources effectively. When you're taking the NCLEX, when you're on exams, and it says delegate emulating the patient to PT, OT, your patient care tech, you have that resource. If it says delegate to, and you're able to do that, you have that. That resource is there. In real life, you may not have those resources available. So understanding the resources that you have and working within that is part of how we plan care, how we understand going throughout the day and ensuring that that we utilize them effectively. All right, other things that are on your concept map, any nursing actions, measures, strategies. There's lots of different things you can pull resources from, including Nursing Central, the Silvestri book, your textbook. And then as you are practicing, you end up with common sense, things that you know work well and things that have not worked. And then we see consistency in care across nurses. You'll see some nurses that are much better at it than others. Some that it just seems to flow very naturally. And they're just really good at being a nurse. It's, I don't know, I think they were like born, maybe they've been nurses in other lifetimes, I'm not sure. And then make sure you're citing the rationales for all your interventions, especially on your concept maps for both tomorrow as well as the ones that you do in your clinicals. So when we're achieving patient outcomes, we implement care to meet patient outcomes. Our intention is to always improve our patient outcomes. We don't work to have poor patient outcomes, right? Like we're not hoping that our patient doesn't get better or that they leave worse off than they came, right? Our goal is to have patients return to how they were before they got to us or better. And there may be many interventions that need to be done across time, whether that's they need PT to come in and help, or they need assistance to the bathroom, and then they slowly progress to not needing that. And we have to be able to figure out at what point do we need to intervene and when can we start to pull back because they have met that goal and that outcome is good. And then patient adherence, including families, is incredibly vital to ensuring that we're meeting those outcomes because they're the ones who need to be bought in and ready to continue those interventions as they go home. So when we're looking at interventions, there's some things to consider, including the medical diagnosis. That's always going to be part of your kind of overarching idea of what's happening with your patient. What are those expected outcomes? Where do I actually want to end up in the end? Evidence-based practice for interventions, the feasibility of interventions, acceptability to the patient, and the nurse's competency. So think about expected intervention or expected outcomes. So if I have a patient who says that there is absolutely no way they are getting up and walking around the nurse's station or walking around the floor because they're in way too much pain. But expected outcomes is that you have them getting up and walking to reduce the risk of developing a DVT. And you have plenty of evidence-based interventions to say that getting up and walking is important to reducing that risk. Part of that is acceptability to the patient. Well, how do I get buy-in from that patient to get up and walk? Well, there's part of that is your why. Why is that patient saying absolutely not? I'm not getting up and walking. And asking, so tell me what's going on. Why, not why. Is there a reason that you don't want to walk? Well, I'm in too much pain. I don't like to walk. My shoes feel funny. These socks are terrible. Whatever the reasons are, see if there's something you can do to intervene to make that to where they're not so against it. When you're writing your interventions, be creative and thorough. They don't want to walk because those socks feel funny. What shoes do they have that they came in? Put their shoes on. Get them up and walk in their shoes. There's no law against that. Make sure those interventions are achievable. If it says that they're gonna walk a mile around the nurse's station, is that actually achievable? Could be. And make sure that interventions are related to the outcome statement. Ensure that they are within the constraints of anything that could be happening, so whether it's staffing. It certainly should not be tied to money or materials because they often are restricted. Be realistic and ensure that they start with the nurse will. The nurse will work with the patient to have them walk around the nurse's station 4 times to reduce the risk of. There's also direct care versus indirect care. So some examples: medication administration, IV infusion, counseling, teaching, etc. Versus managing the patient's environment. That can be related to safety, infection control, using the environment to help reduce pain by distraction, ensuring that you're doing documentation, and then any interdisciplinary collaboration count as indirect care. This is using the medical diagnosis and priority of dehydration. So this one has the patient state they've not been able to drink or eat for 48 hours. We have dry mucous membranes, decreased output, and concentrated urine. So the expected outcome is the patient will have moist mucous membranes in 24 hours, risk skin trigger in 24 hours, and patient's intake and output will be balanced in 48 hours. And interventions is the nurse will assess urine output every hour, assess mucous membranes and skin trigger, provide specimen collector in the toilet, assist patients in the toilet to void, have patient urinate in specimen collector, encourage patient to drink as tolerated, give IV fluids as ordered, and teach patient to void in specimen collector. All right, and the final step of the nursing process is evaluation. So, or the responses. So how did the patient actually do when it comes to your interventions? And this is really quality when it comes to the healthcare setting. Did you make an impact? Did you reach those outcomes that you were striving for? And were you effective in what you've been doing as you cared for your patient? The evaluation is going to be ongoing. It's not just a one and done. It is especially for those ones that are longer lasting. So, and then when it comes to your concept map, goal met, not met, or partially met, and then you want to know based on the data. You from that information, you modify your plan, especially if it was unmet. Why was it unmet? Was there something that needed to be changed from the very beginning? Was it something that the patient just was not on board with at all, or was not appropriate? Did you have a massive change in the patient's overall care? Like, did they completely decompensate and you were getting ready for them to be able to be discharged home, and now they've just decompensated and you need to just start over, versus it was partially met and you just need to tweak it a little bit. So we want to make sure that there's no errors and you ensure that the plan of care is appropriate and relevant. All right, there's several different concept map examples, where we start with the patient and then these are not, color coded, or this one's not. I find them much easier to follow when they are color coded. So in this example, it's a gas exchange, excess fluid volume, fatigue, activity intolerance, decreased cardiac output. Patient has dyspnea or apnea, weight gain of 15 pounds over the past month, fatigue, weakness, frequent cough, lack of appetite, and edema. So it has things to do related to those problems. So his main issue is patient will verbalize decrease in respiratory symptoms and weight will return to baseline within 5 days. So everything is related to that. So, but imagine that he's congestive heart failure. This is one where it's not a specific thing, but it's talking about nursing process where we have assessment diagnosis should be priority planning, implementation, and then evaluation, and where those different things each fit in. Here's a concept map for hypertension, including modifiable risk factors and non-modifiable risk factors, what exactly we can do for each of those. So it's important when you're looking at medications that there are interventions you can talk to your patient about that are specific to medications. So education on those, as well as potential risk for injury, risk for falls, risk for non-compliance. All of those can go along with medications, which oftentimes we forget because, well, we're giving them the medication while they're in the hospital, so we forget to include that as a potential for a problem when they get discharged. All right, so we have this patient. They report to the emergency department after a significant fall. She slid and fell on the ice while shoveling her driveway. She complains of pain 9 out of 10. She's crying and says, "I am in so much pain." Vital signs 98.9, 118, 22, 138 over 96, and 95%. She is on 2 liters, but she takes it. X-ray shows a fracture of her left arm. She's a pack-a-day smoker, uses 2 liters of oxygen nasal cannula, probably while she smokes, if we're going with. She has a history of chronic diabetes, or chronic bronchitis, diabetes, hypertension. She takes hydrochlorothiazide, 25 milligrams PO daily. Metformin, 500 milligrams PO twice a day. Atrovent, 2 inhalations 4 times a day. What priority would guide your nursing care? What are we going with first for this patient? Pain. Yeah, absolutely. I mean, everything else is pretty decent. Why are her vitals like that? Pain. Yeah. I mean, 118, 22, 138 over 96. That is acute pain right there. She's reporting pain 9 out of 10 and she's broken. Right? So I'm very happy. I am okay with those vitals. If I can get her pain under control, I suspect that those vitals will be better. Check her protein. So at this point, the potential pain medication that I'm giving her, I'm not too concerned with those. I mean, that's a very good thought, but I'm not too concerned. Okay, so pain, priority assessment, pain. And our objective information, blood pressure, pulse, respiratory rate, Her diagnosis is that she has a fracture of that left arm. Our expected outcomes, patient will state pain is an acceptable level of 3 out of 10 within 24 hours. I'm guessing this patient is not staying with us. It would be within 3 hours. Vital signs would be stable within 24 hours, or at least back to baseline, be another one. But medications, Percocet, 1 to 2 tabs every 4 hours as needed for pain. And then interventions, between 5 and 10 interventions. So the nurse will assess pain hourly in PRN, assess type, amount, location, duration. So we're getting specific on how we're going to assess the pain. Assess nonverbal cues. So is she grimacing? Is she holding your arm? Whatever that looks like. Administer Percocet 2 tabs now and every 4 hours. Reposition patient PRN. Use distraction, apply ice, PRN. Teach patients to notify nurse if pain is greater than 7. Honestly, I would wait until 7, but that's me. I'd probably put that as a 5. Because how long does it take for oral pain medications? 30 minutes. Takes 30 minutes to an hour for oral pain medications to start working. So I would not have her wait till her pain is a 7. As well as time is a 7, another 30 minutes to an hour. She's going to be, yeah. All right. So we utilize SBAR to communicate the information that we have gathered on our patient. It is situation, background, assessment, and recommendation. It is how we give information from one provider to another. That can be from nurse to nurse, from nurse to X-ray tech that's taking their patient away, to nurse to physician, NP, PA, whatever. So it is your down and dirty information on your patient. This is not a 4-hour lecture on what is happening with your patient. This is our, I don't know, let's make her a 75-year-old female patient, slip and fall on ice with a left humerus fracture, pain well controlled with 2 Percocet, awaiting surgery. She's been NPO since she came in. I've had coffee this morning at 5 a.m. Otherwise, nothing else to eat or drink. Surgery should be at 3 o'clock this afternoon. Patient has a history of, I got to go back. Chronic bronchitis, diabetes, hypertension. She did take her morning medications, including hydrochlorothiazide, metformin, and Atrovent. She's a smoker, pack a day, uses 2 liters nasal cannula regularly, and her vitals are back to baseline. Most recent set of vitals are heart rate of 98, respiratory rate of 16, blood pressure 122/80. And she's 94 on 2 liters. Pain is a 4 out of 10. She's resting comfortably. She is in a left arm splint. And she's just waiting to go to OR when they're ready for her. Like, that is your down and dirty. It is not a whole plethora of information. All right. Questions? Because we're going to start oxygenation when we come back. I always forget like what our times are supposed to be, but I really don't want to get into oxygenation. Okay. So let's come back. Let's be back at 12:15. Does that sound good? Sound okay?
Do what you guys. I was like, yeah.
If not, like,
This one, I'm gonna find it. I'm watching my camera. Where's your phone at? It's like so old. I've never.
I'm sorry. I a terrible time getting my food. It's my counter. My daughter texted me, she left. My lunch only matters. She goes, can I take this to lunch? I did, well, you're welcome.
And like.
No, yeah, like I think it's somebody. My family keeps sending me things like.
We are oxygenation, and I'm gonna do my very, very best to keep it not senior level. Because that's normally what I teach is seniors, and we get really into the weeds. So if you start giving me blank stares, remind me that this is your first semester, because I'm sorry. I'm gonna have to stop myself. Because I get really excited about the patho of things and how things work, and then I go off, and I have to be careful. So we're gonna talk about oxygenation, which goes hand in hand with perfusion. So you cannot have one without the other. And so that's why lungs and heart go hand in hand. They are buddy buddies. Okay, so when we talk about oxygenation, perfusion, you can have oxygenation and not have perfusion, right? So if things are going round and round, but oxygen is not getting in, the blood is perfusing just fine, right? Things are going round and round. Blood is going where it's supposed to, but if that blood is not oxygenated, we are not actually getting that oxygen out to where it needs to go. So normal vital signs, this is straight from your textbook. Heart rate 160 to 100 beats per minute. Blood pressure 120/80 is our classic normal, or 90 to 140, 60 to 90 for diastolic. The American Heart Association is saying that the lower the better, especially when it comes to our diastolic. Respirations, according to this textbook, from 12 to 20. Our skin, we like it pink. Guess what? About over half of this room is not pink. Right? Maybe like right here we're pink. Right? So when you're documenting, if I were to document Sandy as pink, that's inaccurate. Right? Or if I were to say Lola's pink. Right? So make sure that you're documenting according to your patient accurately. But we do want them warm. That is not hot. It's not hot to the touch. But it also should be appropriate to the conditions of the room. Right now, my skin's a little cool. It's a little cool in here. I'm sitting. I haven't really been doing anything. My skin is a little cool to the touch, but that is the skin that is exposed. If I were to go underneath my clothes, it actually is warm. And it should be dry. We should not be sweating profusely. Right? So pupils equal, round, reactive to light, and full stops 95 to 100. In Colorado, 90 is acceptable in Colorado. Higher altitude is okay. But NCLEX purposes, 95 to 100. Okay. All right. So respiratory physiology, when we think about, yes.
I just had a hospital question, not like textbook. So for oxygen to 90 to 100, like even at my previous hospital, that's always just like the normal range is. Why is that compared to because I was not we were at higher altitude there, compared to here, how it is higher altitude, and so they give that leeway.
So some of it has to do with how the patient is presenting. So if your patient is presenting, say you're at lower altitude, sea level, and your patient is at 92%, if they are mentating okay and they are not having any signs of difficulty breathing, I'm okay with 92%. If they're at 92% and they are actively showing signs of difficulty breathing, I'm putting them on oxygen. Because we are not going to treat the number on the screen. I am treating the patient. Because there are conditions that will impact what the number on the sheet says. Like if a patient has carbon monoxide poisoning, they will read 100%. But it's because the carbon monoxide has replaced the oxygen with hemoglobin. So, yeah. All right, so pathophysiology. We breathe in our good air, we breathe out carbon dioxide. That gas exchange happens at the alveolar level. Think about them as beautiful little sacks of grapes with capillaries surrounding them. And they help us to make sure that that wonderful oxygen goes round and round when that gas exchange happens. When we talk about inspiration and expiration, we need to make sure that we understand that inspiration is an active process stimulated by chemical receptors in the aorta. It is like prompting us to breathe. Now, we're not sitting there thinking, gotta take a deep breath, unless we're doing like some mindfulness or something. And then it's a passive process for expiration. Pulmonary circulation, blood moves to and from the alveolar capillaries and through that capillary membrane for gas exchange. When we have a patient who has had surgery, they've been laying in bed, they have not been doing these nice big deep breaths, we can have alveolar collapse. And those alveoli can get kind of sticky together, making it to where that gas exchange does not happen or does not happen as efficiently. Patients will start to get that nasty little like wettish cough, but they're not coughing anything up. We need them to take those big deep breaths. It helps to expand those alveoli so we can get them back with that beautiful gas exchange that happens when capillaries be wrapped around them. We do need to understand that that oxygen transport system requires both the lungs and the cardiovascular system to be working properly together. Otherwise, it's kind of a half-done job. Our lung volumes, we talk about our FVC, which is our forced vital capacity. So what can we breathe in? What do we breathe out? And then instead of spirometry, we talk about in terms of helping our patients to get those alveoli open. For neural regulation, our CNS system is responsible for helping to ensure rate, depth, and rhythm. That's going to be really important when it comes to other conditions that impact our patients. When we have blood sugar that's too high or too low, the patient has had a head injury, or if they have had a stroke, there are conditions that impact how fast does my patient breathe, how deep. When I have a patient whose blood sugar has gone really high, and we have changes in our carbon dioxide levels, our patient does Kussmaul's respirations. It is a very fast and deep respiration, and we end up seeing them do these respirations that are so fast and deep that if you try to do them on your own to mimic it, you probably would end up passing out because it's such a unique way and to do it, your body just can't handle it if you're not trying to blow off CO2. When it comes to steps in oxygenation, we have ventilation itself, which is moving gases in and out of the lungs. Perfusion is the ability of the cardiovascular system to pump blood round and round. Ideally, that is oxygenated blood out to the tissues and then pulling that deoxygenated blood back to the lungs to be reoxygenated. So you have ventilation and perfusion. You've ever heard of a VQ scan? It's actually what VQ stands for. Where they got the Q out of P, I'm not sure. And then diffusion is that exchange of respiratory gases in the alveolar and capillaries. So we have ventilation, perfusion, and diffusion. Here's our beautiful alveolar sacs. That gas exchange that's happening there. There's millions of them. We need that alveolar sac to be nice and expanded so that the capillaries are all around it and that capillary bed can allow that diffusion of gases to happen. Again, if those alveolar sacs are smushed about raisins, so I think grapes is such a great way to think about alveolar bunches. If they get all shriveled up, like little raisins, then the capillary bed cannot effectively exchange gases. And if you are not effectively exchanging oxygen for carbon dioxide or vice versa, then you are not going to have good oxygenation. If you do not have good oxygenation, you cannot have good perfusion. The thickness of the alveolar capillary membrane affects the rate of diffusion. It needs to be that singular cell wall to be able to do proper diffusion, but as it smushes, we end up with a thicker cell wall, which doesn't allow good diffusion. When we talk about a patient's blood levels, talk about hemoglobin and hematocrit or H&H. That's it's an important blood value because hemoglobin carries oxygen and carbon dioxide, part of what is happening at the diffusion level. So if a patient's hemoglobin is low, if less hemoglobin running around in his blood, what would that mean in the sense of a patient's abilities? Low hemoglobin.
That's not
Less what?
less ability to transport oxygen and carbon dioxide.
Excellent. So what would that look like in terms of our patient? How would that present? How would that present? How would a patient act? Low what?
The
Low pulse ox, okay. But what else? How would they, what complaints could they have? Dizzy, all right, I like it. What else? Decreased energy, yeah. So when we start to think about what patients, when we have a medical issue or a lab value, what I want you guys to think about is what does that actually present like in a patient? Because you're going to get a chief complaint often well before you have a diagnosis. Patient comes in complaining of dizziness and headache. Patient comes in with chest pain. Patient comes in with a productive cough. So think about what does that look like on the other side of that chief complaint. So it's important to remember how that gas exchange happens, and then how is blood flowing through the body. This is all learned in A&P as well as patho. So arteries carry blood away from the heart in every instance. Arteries carry blood away from the heart, including when it is deoxygenated and carrying it to the lungs, correct? Oftentimes we like to say, oh, arteries carry oxygenated blood. It's that poor. But it's much easier to say arteries carry blood away from the heart, period. Arteries carry blood away from the heart. Veins carry blood to the heart, which is generally deoxygenated blood, except for when it is going from the lungs to the heart. So much of you guys do not think about. We talked about that in 420.
It's in our other class.
Really? Output and stroke line? Okay.
You wanna go over?
Okay, okay. Wow.
Yeah.
I mean, we talked about it in 420. Oh my gosh. Okay, so cardiac output is the amount of blood that leaves the left ventricle each minute. It is how much can that left ventricle pump out in a minute? How much is that able to do? Right, it is. But stroke volume is how much can that left ventricle do with each beat. Okay. So volume, with stroke volume, think it's each time, every single time. Okay, every contraction, every beat, that's a volume thing. Versus cardiac output is how much can that left ventricle do over time, so it's over a minute. Right? And cardiac output, you need the heart rate plus the stroke volume in order to figure out cardiac output. Give you just general 50 beats a minute, 60 beats a minute. Plus you need to know what the stroke volume is, which you get from either invasive measurements like a art line or through ultrasound, like a echo. Preload is the end diastolic pressure. So what is that pressure within the chambers of the heart at the end of diastole? And then afterload is the resistance to the left ventricular ejection. So what is that pressure that that left ventricle has to pump against? And what you'll hear about specifically in pharmacology is this medication works against preload, this medication works with afterload, and that's where that's coming. So things that impact oxygenation. Anything that's going to decrease oxygen. Specifically our oxygen carrying capacity. So if I don't have enough blood in my body, so think of that hemoglobin. If it is outside my body, like I had some sort of massive trauma and I left my hemoglobin / blood on the sidewalk, just hypovolemia, left it on the sidewalk, I have decreased my oxygen carrying capacity because my hemoglobin and hematocrit usually goes with that, is now on the sidewalk rather than inside my body. There is other ways that you can have hypovolemia because you have third spaced it into other parts of your body instead of it being inside your vessels. So think about your patient who has a huge abdomen filled with ascites. All that extra fluid is not where it's supposed to be. Yes. Yes. Yes, it's cardiac output times stroke volume, yes. Okay. You decrease your inspired oxygen concentration. For some reason, the inspired oxygen concentration is reduced. We can have that through bronchial constriction. We can have that through what? Smoking, yeah. So all different ways that we can decrease the inspired oxygen concentration. You can increase your metabolic rate. So you increase that need for more oxygen. Anything that impacts chest wall movement, so pregnancy, obesity, neuromuscular diseases like Lou Gehrig's disease or ALS, where it does not allow for chest wall expansion. Musculoskeletal abnormalities where you have like concave chests, traumas, massive like flail chests where you have multiple rib fractures in multiple ribs. Any sort of central nervous system alterations, particularly when you have brainstem injuries, chronic disease, especially anything with respiratory system, and then opioids, because that's going to reduce your respiratory drain. We look at the difference between hyperventilation and hypoventilation, and they both impact our patients. And you think, oh, but if you're breathing fast, isn't that okay? Problem is, so one thing to keep in mind, I should have mentioned this earlier, our body desperately tries to maintain this perfect balance, homeostasis, right? It's constantly doing things throughout the day to maintain this homeostasis. So at any given point, you're gonna take your blood pressure, you're gonna check your pulse, check your pulse ox. It's going to be different depending on what you're doing. You're going to find fluctuations in your blood sugar, in your even in your need for water. Whatever you're doing throughout the day, your body is attempting to be in this perfect state of homeostasis, right? So our body says, I am desperately trying to stay within this 12 to 20 respirations a minute. And then you go and start to hyperventilate at 40 breaths per minute. This is not what we're supposed to be doing. When you start to do that, you increase the amount of carbon dioxide that is going out, and you mess up homeostasis. Not you in particular, the person, right? Or if I slow my respiration way down and I breathe 4 or 6 breaths per minute, I'm changing that homeostasis, and the body is trying desperately to get back to that. So I am not oxygenating, do not have enough, and I end up hypoxic, So either way, I am messing up the pH, right? So then what does that look like for my patient? How are they presenting? I will end up with altered mental status. Which is why if my patient has some kind of alteration in oxygenation, altered mental status is one of your very first signs. And when we think altered mental status, you're thinking, oh, my patient is off the rails. No. Sometimes it is as simple as repetitive questioning. Or them seeming a little bit more sleepy than they were 20 minutes ago when you came in to get them up for the bathroom. And because nurses are the ones who are at the bedside and caring for them the most, or your patient care tech comes in and they're like, something's just a little bit off with this patient. I was in just a little bit ago and now they don't seem quite right. Or you go in and you've had them and it's your third day in a row of having this patient and they've remembered your name every other time and this time they don't remember your name. It seems so small, so insignificant, but it needs to be enough that your spidey senses go off and you say, whoa, whoa, whoa. What's going on? Because I'm going to tell you, cyanosis, which we think, oh, yeah, respirations are bad. Cyanosis is a late sign. If you come in and your patient is cyanotic, they've been headed downhill for a bit. So we also need to think, because lungs and heart are besties, what other things can impact oxygenation? Well, oh, yes,
I had a question.
yes.
It has to do with slide 75. Also,
Which one is that?
the blood flow regulation.
Oh, this one?
Yeah, I'm thinking about ejection fraction and then how that has to do with alterations in rest functioning, if they have a relation at all.
Yes, but it's going to be with the cardiac function.
Yeah, that's
Yes. Yeah, so when it comes to our patients who have problems cardiac wise, they also impact oxygenation. So think of your patient who has a history of congestive heart failure. If they have a history of any sort of having a cardiac event, they've had an MI or acute myocardial infarction. If they have had if they have a history of any sort of arrhythmia where they do not have the strength of contractions, where they are not getting a good contraction, then they are not getting the same type of circulation that they would if they were having a normally functioning heart. When we look at cardiac output and we're measuring that, that is part of what we're concerned with. And we have medication that we can give them, but they don't always do well on it, especially our older adults. They may not tolerate it, can make them dizzy, give them generalized weakness, and increase their risk for fall. And if they have an arrhythmia and we're trying to reduce their risk for a stroke, they're also on a blood thinner a lot of times. So if I'm increasing their risk for fall, and they're on a blood thinner, that's like a deadly combination right there. When we're looking at ejection fraction, which is a measurement that's taken with an echo, we'd like to see that above 60%. So that's how well is that left ventricle functioning. Once it's below a certain point, they start to look at heart failure and even depending on the patient, whether or not they need a transplant. And that definitely impacts how well that patient functions. Are they able to get up and do the things that they want to? Do they have weakness in pursuing even simple tasks like their ADLs, able to bathe themselves, or is it so exhausting because they're just not perfusing the way that they need to. And then when it comes to like peripheral circulation, can that blood get back to the heart? The example here is they have swelling in their legs, also swelling in their belly. They can get excess fluid around their lungs, which also leads to further problems when it comes to oxygenation because they're not able to have good gas exchange. We also look at the different developmental factors between kiddos, like little guys, our school-age kids, young adults, and older adults. Keep in mind that unless there is a medical reason, older adults do not automatically have cardiac problems or lung problems. They generally go into older adulthood with a medical problem that was pre-existing. They don't just automatically have a cardiac or respiratory problem. Lifestyle factors absolutely can contribute. We recommend cardioprotective nutrition, diets rich in fiber, whole grains, fruits, veggies, antioxidants, avoiding high-fat foods, exercise, 30 to 60 minutes per day. Patients have a lower pulse rate, blood pressure, decreased cholesterol levels, and then they are finding that muscles have greater oxygen extraction when they are exercised regularly. Other lifestyle risk factors, smoking is associated with heart disease, COPD, lung cancer. The risk for lung cancer is 10 times greater in a person who smokes than those who do not smoke. There is further studies that are going to be coming out, I'm sure, on people who vape. That is a different type of lung damage that's happening. We're seeing popcorn lung that's causing severe damage to the alveoli because of the high temperatures from vaping that are happening to the destruction of the alveoli. So it's different type. We thought, oh my gosh, we're helping these people by getting them off from smoking and instead destroying their lungs through a different mechanism. Excessive use of alcohol and other drugs impair tissue oxygenation, particularly as it starts to decrease the respiratory drive. And then the long-term use of alcohol and other drugs definitely have far more damaging problems there as well. And then stress, the continuous states of stress or severe anxiety increases the metabolic rate and the oxygen demand of the body, as well as releases free radicals, which are also found to be damaging to the heart. So when it comes to the nursing process, we look at the assessment and in-depth history of the person's normal and present cardiac function, cardiopulmonary function. So how are they doing right here, right now, and how do they normally do? So if you have a patient who is doing well and you're seeing them for something else, then you are fine.
For smoking, whenever they're offered like other methods of like nicotine patches, do those still affect the lungs at all? Or is it because it's a different group, it only affects, like how does that make?
So yes and no. So smoking itself is lung damaging, but the nicotine is damaging to as a drug is damaging to the small vessels and cause constriction. So we see a lot of retinal damage, kidney damage from the nicotine. So it's constricts vessels, small vessels. So we still see the damaging properties, but not as bad. So like when patients come in, and, you know, we tell them we can't smoke while you're here, and offer them a nicotine patch. It is obviously better. However, it's not ideal. I mean, we don't want them jonesing while they're with us, but, it's not ideal. But, yes.
I've seen some positive studies, people using nicotine patches for like nootropic effects. So like caffeine, like help their brain think better, more clearly.
I had not seen those.
That's
I had my mom, who is a little off the wall, recommend that I use nicotine to help my, post-COVID lung. She also recommended ivermectin, if that gives you any idea. I asked her for the evidence-based practice articles on the nicotine and post-COVID lungs, and she has not provided that information to me, so. But I had not heard of it must be the stimulating aspect of it. For the, like, the brain power aspects.
I was kind of just thinking about, and my husband does it, because he says it quiets his brain.
It quiets his brain, so
Yeah,
I wonder if it's stimulating aspects.
Yeah, I was just curious, because I hate that he smokes, and I'm like trying to give him other options, but
Yeah.
he's like, it quiets his brain. So he doesn't want to do medication, but he likes the fact that it just numbs, I don't know what it does, but just
Huh.
quiets all the voices. Not schizophrenia.
Wow, okay, that's like a conversation. About it, side note. No, getting very personal here, my brain is quiet when I do puzzles. So I totally get that. The only time my brain is quiet is when I do puzzles. So I understand that. I can't do puzzles while I'm at work though. It's very distracting. Although that's not true because Dr. Morris has a puzzle going in her office all the time. Yeah, she has a puzzle in her office all the time. But yeah, and part of it, obviously it's going to depend on how much nicotine you're taking in. You know, if you are, do y'all know how to figure pack a day, or pack history? For, like if you say so-and-so is a, pack such and such pack history, it is how much you smoke, times the years smoked. So if it was like half a pack per day times 5 years, they are a 2.5 pack smoker versus somebody who is a 2-pack per day times 5 years, they are a 10-year pack smoker. That makes sense? Okay, so we're talking to our patient, we're asking them what's going on. They tell us, oh, I'm just feeling really short of breath. I don't know what's going on. And do you use anything for oxygenation? Oh yeah, I have to sleep with a CPAP or BiPAP. Or I use 2 liters of oxygen at night. Or I use 2 liters of oxygen all the time. Or no, I don't use anything. I don't know, I just all of a sudden started feeling really short of breath. It's kind of weird because I got this sting at the same time. It's very itchy, it's red, it's swollen. Are you allergic to anything? No. Not that I'm aware of. Do you take any medications? No. Right? So we're asking all these questions. We're doing our full assessment of our patient. We're looking at that sting. Oh yeah, sure enough, there's like a little sting right in the middle. It's like raised, swollen, red, irritated, painful. Any labs that might we order any diagnostic tests. Things that our patient might report to us, chest pain. And there's a variety of types of chest pain. There's pleuritic chest pain, which is like what it feels like on the inside of your lungs. When you have that really awful cold and you take that deep breath and you're like, oh, my lungs hurt. Pleuritic chest pain. Versus, yeah, like it hurts outside. Dyspnea, they report that they are short of breath or they appear short of breath. Wheezing, other types of lung sounds. They report a respiratory infection, generalized fatigue, cough, with or without coughing something up. What kind of health risks do they have? Do they work at the steel mill? Are they working on a farm that just got sprayed with chemicals? Do they have any allergies, medications? And then we're gonna do our physical assessment. We're gonna inspect. We have good equal wall, chest wall. Nice expansion on both sides. Skin, mucous membranes. Level of consciousness, is it normal for them? They have a family member that they seem a little bit off. Ask the family member. They're answering all the questions appropriately, then you don't need to, but if they seem like, oh. Check legs, feet. Are they swollen? Are they normally swollen? Ask what is normal for them. And then for auscultation, we want heart and lung sounds, front and back. Any sort of abdominal swelling. The abdominal fluid. When it comes to diagnostic testing, there's lots of different things that we can do. General blood or serum testing. So CBC, CMP, which gives us all of our different electrolytes, cardiac enzymes. Cholesterol levels are not ever considered emergent and patient needs to be, they need to be NPO before having cholesterol levels done. Chest x-ray, chest CT, rule out pulmonary embolism. That's with a dye. They do a cardiac catheterization, checking for any blockages. Non-invasive, we do TB test, Holter monitor, that's going to go home with a patient. It's a portable EKG that's checking them, keeping an eye on them for however long they order it, 24 hours to a month, sometimes as long as 3 months. A chemical stress test versus a treadmill stress test. Pulmonary function testing. They can do electrophysiology testing. So all depending on what is happening with the patient. A pulmonary angiogram can look at pulmonary vessels. That is very important to check allergy to dye as well as kidney function. And if your patient with any kind of injectable dye, so including with a patient who gets a cardiac cath, because they'll get dye with that as well. They do need to, if you're on metformin, it's a huge thing. This is a hint for farm as well. If they are on metformin, they need to hold their metformin because metformin is very, very hard on the kidneys, and any sort of dye for testing. So whether it's a CT angiogram, it's like a pulmonary angiogram, or a cardiac cath, it if they're on metformin, we have them hold it before their test, if they can. If it is emergent, then they do not take it for the 3 days after. And we have them drink a lot of water to flush out their poor little kidneys. 'Cause it is rough. So, we can do bronchoscopies, which we're literally taking a camera and shoving it down your throat into your lungs to look and see what kind of yuckiness is hanging out in your lungs. A TB test. Do you guys do any of the making the wheels in lab? Practicing making the wheels? You actually can do, some of those, little pads can make the little wheels. So it's 1 ml of the PPD, testing material drawn up in a turbulent syringe, and then it's very shallow, and you make, this is called a wheel. Like a wheel. And then we determine what that looks like in 2 to 3 days, depending. When you measure it, you only measure the raised section, not the entire reddened area. So this is measuring the entire reddened area, which is incorrect. This is only measuring the like part that is raised and elevated off that original spot. So not this whole reddened area.
Is it always blanched, the center?
It generally, or it actually will start to like it blister or like ulcerate. It's very different than like the little spot when you don't have TB. So, yeah, it looks really bad. All right, so priorities and planning. When it comes to our patients who are having trouble with oxygenation, lots of different things you can do depending on what is going on with your patient. We can do activity intolerance, decreased cardiac output, fatigue, ineffective breathing pattern, ineffective airway clearance, risk for imbalanced fluid volume. So it all depends on what your patient's original medical problem is. So if my patient is admitted for pneumonia, what priority would you want? They're admitted for pneumonia. Either one of these or one of your own. What priority? Impaired gas exchange, okay, what else? Ineffective airway clearance, yeah, because you can get those nasty, gross, like thick. Okay, well, is it risk or are they actually infected? They're admitted with pneumonia, okay? Risk for aspiration, okay. What else? Is there more for a pneumonia patient? Anybody had pneumonia in here where you're just like, feel like a load of hot garbage, right? So anything else you want to throw up there, knowing what that feels like? Fatigue?
So there's so much pyramids.
You're not getting it out.
There's either insert. Then like stuff, you know, for babies, how they do that, or they flush it out and it all comes out of the flush.
Neti pot.
Yeah, it's like this.
Oh, we have a game tower, but I
Like a
don't know
neti pot.
how willing you are to shove it all the way down your throat. You have a gag reflex. Ella?
I'm not sure if this would come into priorities, but I was thinking like ADLs, they have a chest tube.
Yeah, ADLs are hard if you are fatigued. So when it comes to, so we add that to our nursing priorities as fatigue, and then that can be part of our planning is how do we help that patient with their ADLs? So is that aspect of helping to plan out those ADLs and help them with that?
Something interesting, I had severe pneumonia when I was 2, was hospitalized for 3 weeks, had 4 chest tubes.
And I'm missing part of my left lung now, so that's another intervention. Planning would be visualizing the capacity of their lungs after surgery.
Yeah, so education with that and
That'd be a reassessment too.
absolutely, absolutely. All right, and then when we talk about health promotion, what vaccines? Patients need vaccines, even if they've been in the hospital sick. So talking to them about that, education with that, helping to eliminate risk factors, reminding them hand washing, eating regularly, regular exercise. When somebody's coming back from being really sick, taking that pneumonia, for example, it takes a bit to get their energy back up. So maybe they need help with their ADLs at home, with getting their meals, ensuring that they're able to get to and from the bathroom safely. Environmental pollutants, avoiding secondhand smoke. If they do smoke, having them stop if at all possible. Work, any pollutants that they may be exposed to. We got a notice on my phone yesterday that we were at poor air quality in the springs, and I was like, because I generally, because of my stupid lungs, I don't generally leave the house if it's poor air quality, because it makes my breathing so much worse. So those kinds of things are really important to pay attention to. All right, so when we look at that acute care, if we have a patient who has shortness of breath, how do we help them manage that? Well, some of that is, well, thinking of that big nasty pneumonia in there. We can help break up that mucus by hydration, humidification, and probably on oxygen. So let's humidify that oxygen because we live in Colorado and it's really nasty to have oxygen that's not humidified. You do not need an order to put humidification on your oxygen. FYI, keep that in mind. Put humidification on there. Nebulization, so that's getting those nebulizers in. Teaching the patient about popping and deep breathing techniques. Are they gonna like it? No. I'm gonna tell you right now, talking to them about how, especially after they've had a nebulizer, they're gonna be coughing. Get that gunk out. Spit it out. Don't swallow it. Spit it. Here's a trash can right next to you. Here's Kleenex. Spit it in the Kleenex. Throw it away. There's some hand sanitizer. Handy sandy right here. This look, right? Mobilize those secretions. Get them out, right? Chest physiotherapy, that is banging on that chest. I have a picture. Oh, no, I don't. Ambulation, getting them up and out of bed. Moving. Positioning. Positioning is another great intervention. I do not want my patient flat on their back if they can't breathe. Test question in. Your patient can't breathe, and one of the options is sit them up. And it seems reasonable, sit them up. Incentive spirometry, you do not need an order for incentive spirometry. Get them breathing. Oxygen therapy, inhalers, nebulizers, all of that's going to be based on physician orders. Chest physiotherapy does require an order, but RT is really good about saying, hey, let's try this, see if it works. Suctioning does not require an order. You can also give the patient the power to suction themselves. If they do not want to cough stuff up, give them the suction catheter. If they're awake and oriented. Ellen.
What's the, when respiratory therapy comes in and they take their blood and put it on the cool little like cell phones?
Oh,
That's the arterial gas.
when they do, yeah,
ABGs.
ABGs.
And yeah, all that. Would that be an implementation or
Would that be what?
an implementation?
That does require a physician order, but monitoring ABGs would be part of that. So why do we encourage patients to cough and deep breathe? Well, number one, we want to make sure that they know how to cough and deep breathe. And it sounds silly, but not everybody knows that that's not deep breathing. You want to tell them, okay, you want these nice big deep breaths. You want to feel all the way down here that you get nice big deep breaths. And if they had any kind of surgery that includes the chest or belly, show them how to splint with a pillow when they cough, because that hurts. And if it hurts, they don't want to do that because we're human beings and we don't want to hurt, right? So give them a pillow or a blanket, fold it up where it fits them, because if you have a tiny little, 5'2" Italian grandma, she's not gonna want to do that because they're scary, right? So make it tiny and their size and show them how to do that. And then give them the incentive spirometer and you say, especially if they watch TV, at the top of every hour, you're gonna do this 10 times. And then just show me how to do it. Okay? And what do? Do we suck in with the incentive spirometer or blow out? Okay, suck in. It's an incentive spirometer. And it even has directions in the thing. When you open it in the bag, it has how tall is the patient? Are they male or female? There's paper in there. You can find your patient, how tall they are, what to set it to. So you're not setting it to where it's like way too much for your patient. And then part of what your education is has to do with why we tell a patient to do this. If they start to feel icky, they start to feel increased fatigue, dyspnea, if they're having chills, if their cough is getting worse, have them do 10 sessions of their incentive spirometer and 3 really big coughs. Give it a few minutes, like 10-ish minutes, to see if that starts to make any of these signs or symptoms better. Generally, they feel crummy because they're not clearing out that junk that collects in their alveoli, and they just are not doing great. If those don't clear, then they call their healthcare providers. So there's lots of education that goes along with that. But we know if we're not getting that gunk out, it's developing into other gunk. So promoting lung expansion, here's the example of the incentive spirometer. We also can use non-invasive like CPAP or BiPAP. This is chest physiotherapy, also called postural drainage. And they are pounding on the back to mobilize those pulmonary secretions. Best done immediately following a nebulizer treatment because we're more broken up, and especially any nebulizer treatment that has medications that can help with expectorant type stuff, really will get it out. Positioning. It is easier to breathe when you are sitting up than when you are laying down. Especially think about those sweet little old people who slide down in the bed and they start to go like this. And you come in and you don't understand why they can't breathe. Sit them up. If you have to lay them flat, slide them up, and there is a crease in the bed for a reason. But if they get split down and their crease is like up here, then their lungs are smushed like that. So help make their lungs go like this instead of like this. Okay? Yes.
So I was playing soccer this weekend and we played like a really long game. I was tripoding tons of time and it just reminded me of being, when I was a kid playing soccer, being punched on the field. But I felt like it works for a couple seconds, a couple breaths, but you can get a lot more breaths than standing straight up. I feel like I just didn't know why people resort to the tripoding. Is it because they're tired of breathing or?
So it depends on what is happening. And it depends on. So. Were you walking, did you end up walking around like this, like your hands on your hips kind of when you were,
Yeah, or like,
or like that? You are still expanding your rib cage though. If your arms are up like this, don't look at my wife, but at least. If your arms are up like this, you're still expanding your lungs compared to if you're tripoding like this.
yeah, I felt like, I would get tired and I would like tripod, but then after a couple breaths, I felt like that wasn't really helping. It was a whole lot better just to stand and stretch.
So, but you're still doing a different position than just standing like this.
Sure.
So think about what we are looking at when talking about positioning. Sitting up is better than laying down. That's the first idea. The second idea is what is that patient doing without thinking about it? Patients put themselves into tripoding without thinking about it. It's not something that we naturally like put ourselves into this position. It's not a natural position that we go into. And it's not even necessarily like I'm just casually like leaning forward like this. It's a intentional way that our body ends up being positioned to expand that rib cage as far as we can to help get a bigger breath. Where we tend to see it the most, and you'll also see it combined with pursed lip breathing, and our COPDers tend to do it more often because of the mechanism of how their functional breathing is typically. And with that pursed lip breathing, so they'll end up like they're like forcing themselves to do, they're not forcing themselves, their body is doing that. And it's not an intentional thing. Whereas you were like, oh no, this is way more, I'm getting a better breath this way. You had more of a train of thought to it. Does that make sense?
I guess the question was like, why are they really resorting? Is it because they're exhausted and bent over, they can't hold themselves up, or?
Not necessarily, because they'll be in that position even before they are physically fatigued. I'm actually more worried about my patient who has been tripoding and is no longer tripoding because they don't have that power to do that. Because it does take a bit to hold yourself up to get that lung expansion. And if my person has been doing that and they've stopped and I have not done an intervention, I'm more concerned about that because they don't have that power. They don't have that energy going to the muscles to be able to hold themselves up. But also, they may not. If you have somebody who is struggling that much to breathe, they are not necessarily going to have the ability to just be up and walking. That's expending more energy, that's increasing metabolic need, it's so much more than just putting themselves in that position. That help?
Yeah, I just feel like maybe one day we'll know like the perfect position to put someone's arms and back and to get them, instead of just telling them, hey, tripod, does that make it feel better?
You'll see that patients put themselves into whatever position feels the best when it is.
So speaking of repositioning, so would you put a patient on oxygen that's having a little bit of a respiratory difficulty just so that you can get them to the point where they can get up and ambulate? Is ambulating that important?
Not at that point.
Are we?
Ambulating is not important if they're having difficulty breathing. I mean, unless I need to get them like from the car to a wheelchair or from, to get them into the ER, like at that point, my concern is stabilization. Airway breathing and circulation come far before anything else.
All right.
Yeah. I mean, if it's somebody who's like a long-term lunger and And I'm like, yeah, your lights get you up, we're gonna take the 3 steps to the bathroom, like, that's a different, but if it's an acute situation,
Go to bed.
airway, breathing, circulation,
You chart like tolerated or not tolerated.
exactly. So. All right, oxygen is considered a drug. Please, for the love of all things holy, do not smoke around it. No vaping around it. Vaping does have a source of ignition, so no vaping around it either. When you lubricate around the nostril, face, and lips, make sure that it is with non-petroleum based lotions, creams, gels, lip products, whatever it is. And then make sure that you're checking for skin integrity around the back of the ears, especially on your patient whose ears hold up a lot of things. If you have a sweet little old person who has oxygen, glasses, hearing aids, those ears are holding a lot of products. They're doing a lot of heavy lifting on those tiny little ears. So double check also the nares, oxygen tubing for your long-term patients who are wearing their nasal cannulas. Those should be changed out every week. I can guarantee you they are not. And their long extended tubing should be changed out every 3 weeks. Again, I can tell you they probably are not. So keep that in mind when it comes to education. FiO2 is the percentage of inhaled oxygen concentration. And then we adjust oxygen delivery based on the type of delivery device and then how much we're liters per minute. So our oxygen delivery, that's our example flow meter. And we have lots of different ways that we can give oxygen, starting with a nasal cannula. Up to 6 liters per minute, but I can tell you right now, 6 liters per minute is like sticking your head out the window, driving down the interstate, and is absolutely horrible. There are high flow nasal cannulas, which makes 6 liters a minute a little bit more tolerable, but still not great. At 1 liter per minute, you're getting about 24% oxygen, goes up to 44% oxygen at 6 liters per minute. This recommends a humidifier if it's at 4 liters or more. I say in Colorado, if you have oxygen on, it should be humidified because we are so dry. We have negative humidification. We need oxygen. Or we need humidification. A simple mask. It is exactly what you think it is. It is just a mask. It needs to be at least 5 liters per minute at FiO2 at 5. It's about 40%. A simple mask goes between 5 and 8 liters per minute. So once you're needing more oxygen than that, then we need to go up to a non-rebreather. They have these little flappies on the side. A non-rebreather can start as low as 6 liters per minute. A partial non-rebreather is when you take off the little flappies, either one or both. It has the reservoir bag. The reservoir bag does need to remain at least partially inflated when the patient takes a breath in. It generally needs to be more, at least 6 liters, if not more, depending on how big a breath the patient is taking. At 6 liters, it's about 60%. At 10 liters, it's as high as 95%. A partial non-rebreather is 6 to 10 liters. Once you need higher than that, we go to a non-rebreather. Here you can see the little flappities on the mask in place. This is where both of the flaps are left in place. They are one-way valves. And they are left in place. And that is at 10 to 15 liters per minute, and it's up to 100% FiO2 because that reservoir bag stays inflated and they're only giving the oxygen. We also have Venturi mask. It controls the amount of oxygen concentration. We don't really see these very much anymore. It's either like simple mask or non-rebreather. But you may still see them at some of the long-term care facilities. They're anywhere from 24 to 60%, and they're all based on the dial, the colored dial that's at the bottom. And they can be a flow rate of anywhere from 4 to 12 liters per minute. For inhalers and nebulizers, I hate the fact that this picture does not have a what? Spacers, yes.
For oxygen, is oxygen like a standing order? Because I know some medications that the doctor has to order it, but is it more like a standing order, like the nurse does it? If the patient is.
It depends on where you work.
Okay.
This will forever be a hill that I will fall on. Or a hill that I will die on. There we go. I will forever beg for forgiveness rather than ask for permission. If my patient needs oxygen, I will put them on as much oxygen as they need and then ask for the order later. According to nearly every rule and regulation I have heard of or read, you can give up to 2 to 3 liters, depending on where you live, without an order, and then you need to get an order. But I will forever give my patient as much oxygen as they need to get them and then get the order later.
Okay, so I'm just seeing it as like a standing order and then versus just like.
Yeah, in the ER, it absolutely was a standing order. We had a set of standing orders, but it's gonna depend on where you're working. So,
Okay, thank you.
Nebulizers are the other one, and they are medication, inhaled medication that is aerosolized, given over 5 to 7 minutes, depending on how fast that goes. Patients can take both of these at home or in the hospital. Suctioning, used when a patient cannot clear their own respiratory tract. You can do it oral or nasal. And then we can do tracheal suctioning when they have bulb suctioning. That's your good old fashioned suctioning with a teeny tiny little baby. And then a Yankauer, we have our wall suction, and then the Yankauer is the actual suction tip. You can give that to your patient. If your patient is awake and alert and oriented and able to suction themselves, give it to them. Let them suction themselves. You can leave the suction on. They can suction their mouth. If they're salivating a lot, if they have bleeding, let them suction themselves. That's fine. There's nothing to say they can't do that. Unless they're not alert and oriented enough, I wouldn't do that. But and you really wouldn't want to go too far back because it can trigger a gag. And this is what you would want available if your patient is when you're doing your NG, always have suction available. Okay, trach, surgical opening of the trachea to provide an open airway. Patients who require a long-term artificial airway, maybe temporary or permanent. There are 2 different ways that this can be. It could be cuffed or uncuffed. The cuffed actually has the bulb that is inflated at the end, prevents aspirations of liquid, prevents air escape when a ventilator is used. And then uncuffed allows air movement through and around the tube and does allow for it's lesser work of breathing. And patients generally can talk with an uncuffed tube. And then here's the different parts of a tracheostomy. So the outer cannula, the inner cannula. This demonstrates both cuffed and then there's uncuffed.
Is it possible for a patient to clean out their own tracheostomy bowl?
Yeah. Yeah, patients have had it for a long time. Families will clean them out.
you ever get a patient that's like, oh, let me hear my own NG. Okay, I'll get
Not NC, but I have had a patient who's like, yeah, I just need the suction stuff, or a patient who's straight out themselves because they were a paraplegic. And they were like, yeah, I can do it. Okay. If you want to.
And you just want to push the saline on, right? When you're talking.
No.
They should just grab it and just.
Okay. All right, clean versus sterile. We're gonna go over this. Is oral suctioning a sterile procedure?
No.
No, your mouth is a dirty germ hole. Nasotracheal suctioning is sterile procedure.
Yes.
Ah, trachea. Ooh, that's going straight to your lungs, baby. So, sterile versus clean. An easy way to think of this is anything above clean, anything below sterile. Clean, sterile. Clean, sterile. I need gloves. I need sterile. Ball gloves, I need sterile gloves. For any kind of artificial airway, I need sterile gloves. Okay. Tracheostomies do require frequent suctioning. Secretions do decrease over time, which is good. But they do lose the normal humidification of our upper airway. So they need humidification of inspired air regardless of how much they're on. Suctioning can lead to hypoxia. It's very important that you limit suctioning to 5 to 10 seconds at most, and then allow at least a minute to pass between suction passes. So you are literally shoving this down. Suction. Or wait a minute. It can cause a lot of coughing. It can cause hypotension. It can cause arrhythmia. If you were too rough, it can cause trauma to the mucosa of the airway. This absolutely cannot be delegated to a CNA when it's in a hospital setting. Home setting is a different situation because there could have been additional training that's already been done, but in a hospital setting is not delegated to a CNA. It's RT or the RN. Yes.
You're doing trach suctioning. I don't know where I heard it, but would you dial up their oxygen before you do that? Let the guy have like some oxygen or
Only if they've tended to like desat really fastly. If they have been known to desat quickly, you could, but generally since it's 10 to 15 seconds, you're in and out fairly quick. So, but it's at least that 1 minute recovery to just like let them relax. So we have non-invasive ventilation. We have positive pressure and continuous positive pressure or bi-level, so either CPAP or BiPAP. Chest tubes, ventilators, and nurses manage all of these. We work closely with RT when it comes to ventilators. They are the experts, but you do need to understand caring for your patient on a ventilator. Chest tubes, we go into great detail when it comes to them in 420. A catheter is placed through the thorax to remove either air, fluids, or both from the pleural space and to prevent air from re-entering and collapsing that lung. You can have a pneumothorax, which is just air, chemothorax, where there's blood that has collected there, or a hemopneumo, which is both. When it comes to cardiopulmonary resuscitation or CPR, we look at it as CAB. So we want circulation to be going all the time, right? So it is, if anything, we want hands-only CPR to get started. So start those chest compressions, then we look at airway breathing. And we want an AED as quickly as possible. So that's any place, doesn't matter where you are, let's get that circulation going and get an AED on them. Obviously, if you're part of a code team, that's gonna look a little bit different because you'll be doing ACLS. But ensuring that you have, hard and fast compressions are vital. Things to consider. Any patients with sudden changes in vital signs, level of consciousness or behavior has the potential to have profound hypoxia. So think about what could be causing that. Why is my patient acting this way? Why is their vitals like this? Why is there a change in their level of consciousness? What could be going on? Have that why in your head always. Why? Perform tracheal suctioning before pharyngeal suctioning whenever possible. Use caution when suctioning patients with a head injury. It definitely can cause severe agitation. And increase their ICD, their intracranial pressure. The routine use of normal saline into an airway before ET and tracheostomy suctioning is not recommended. We used to just like do drops of saline to help loosen secretions, but it's no longer recommended. And then check your institutional policy for stripping or milking chest tubes. No, don't do that ever. We don't milk chest tubes. Doesn't matter what your institutional policy is. It causes more damage than good. It's evidence-based practice. Don't milk or strip your chest tubes. I don't care what the nurse did before you, after you, around you. We do not milk chest tubes. Do not take the chest tube that is stuck in this person and go like this. That is milking or stripping a chest tube. It's dangerous. It causes increased pressures in the chest. Don't do it. Somebody tells you to do that, say, no, thank you. But you're welcome to if you would like, and I will document that. Thanks, but no thanks.
So is it the doctor that you should?
What?
Right here.
I was like,
Is it the doctor or the provider that?
oh, providers more than welcome to. And I was
Is that just not
happy.
like, is that just not a, is that technique kind of just like frowned upon?
It's outdated.
Okay.
It used to be done all the time. I was taught to milk a chest tube.
Like in nursing school.
Yes. Yeah, milk that chest tube. Get that blood clot out of there. Milk it. And then we went, but evidence-based practice, just note. Evidence-based practice shows that increases intrathoracic pressure. It can actually worsen the condition that the patient has. So no, thank you. But I would be happy to stand here if that is what you would like to do. My kind physician, PA, NP, whoever you think you are, but I document that you did that.
What is milking?
What's that?
What is?
So if you have the patient and they have a chest tube inserted, the chest tube goes to the collection. Right, the collection chamber, which is right there. So the chest tube is inserted, that has the tube that goes down to the bottom. You can see the blood on the floor and that. And you're literally like holding on like right here to make sure you're not ripping it out of their chest. And then you're taking that, and a lot of times they would use like glue. Hold on, it was with the looped gloved hand, you're like holding on and like squeezing it to get more fluid to come out. And then it's collected in here. The idea was, well, if I pull more fluid out, I'm like getting any clots or anything that's been collecting in there that hasn't been able to come out. But it increases intrathoracic pressure, causing more damage to the tissues that are in there. Yes.
So what's a better way to?
If you have like a large clot in there, you can like squeeze, like gently squeeze a clot to break up the clot so that it'll flow out. But that is not milking, like. We're just like gently breaking up the clot. But generally, they're not huge. They're just doing. Okay, exam 2, Monday. Starting at 9:30. Lecture will begin at 11:30. Not gonna do a traditional break for lunch because we have a lot of content to cover. So. Go get food. Cause with an hour and a half for the test, that's what we have scheduled. That'll put us at 11:30. Most of you guys will be done. Well before 11. So feel free to grab food and bring it back. Okay, does that sound good? I was just looking at me like, you're so mean. You're so mean. We just have a lot of content to get through.
So exam 2 is up until today's lecture.
What's that?
Exam 2 is up until.
Up till today's lecture, yes. All right. Anything else?
We'll do meal class and this.
You don't have my possibilities. We don't have my class on Wednesday. Any other questions? You guys tomorrow. Bright and early.
What's there?
So we.